Good morning, everyone. Welcome to the March meeting of the Universal Health Plan Governance Board meeting. I'm just going to give 1 minute to have Isabel let everyone into the room.
Sure,
Good morning. How are you?
I'm here.
Yeah. Okay.
Survived late full session.
Yeah. Okay. Great. Let's get started. We'll start with the roll call.
Helen Belanca,
Here.
Chadwick Chi,
Here.
Amy Fellows,
Here.
Michelle Glass,
Here.
Bruce Goldberg is on leave, Judy Richardson,
Here.
Cheryl Ramirez,
Here.
Mary Lou Henrich, here, Mike Leahy.
Here.
Thank you.
Great. All right, for a quick agenda review, we have a great meeting today. After our executive director report, we're going to hear from our colleagues at the Oregon Health Authority with an update on the OHA readiness report that they will be contributing to our plan. And then we have an excellent guest speaker today, Dr. John McConnell, who's a health economist at OHSU, is going to be coming to talk to us about the economic impacts or considerations for our plan. So we left some time for discussion with that. After the break, we're going to be hearing from Milliman and their operations report. And then that will lead into a discussion about administrative efficiencies, which I know has been a topic of interest for all of us. And then we'll finish up with our committee updates. We only have one vote today besides our consent agenda, and that will be a proposal from Plan Design on cost containment. So with that, I should also note that we have to end this meeting on time today. I'm going to ask all the board members to really be attentive in our discussion about the agenda and what's remaining and help us stay on time. The reason for that is the transition committee will be launching today and they're meeting in person directly after this meeting. So we have to wrap up by 12:30. We won't be able to extend the meeting as we did last month. So let's, I'd appreciate your help with that. Great. And now we can go to our consent agenda. So the only thing on the consent agenda this month is our minutes from the February meeting. Is there a motion to approve the minutes from the previous meeting? Any discussion?
I had couple of things that I wanted to, so I was gonna ask to bring it off the consent so we could talk about it.
Okay, so you're asking to bring it off, that we can bring it off the, well, so in this case, because it's the only thing on the consent agenda, so I guess technically, yes. So go ahead, Mary Lou.
Okay, my two things were, I gave a couple of small edits to Isabel, which are great. I mean, these minutes are amazing. I just want to say that. I don't know how they get them like this detailed. It's wonderful. But I had two things on page 2. In the discussion about why we were stopping committees. It was all fine, except I have a concern saying that committees are ending because their deliverables will be met. The F&R committee, for example, did not believe that we met our deliverables, and that was brought up at the last meeting. So I was just wondering if that piece could be, some of the committees, or I mean, something, because it just isn't a total truth. And I know you brought it up, Helen, so I just.
Yeah, I think I wasn't stating that the committees had. So I was stating that the reason why we decided to end the committees in March was that we anticipated that they either had met all their deliverables or they will have by the end of March. And that was the rationale for why they were ending in March. And that remains true. I appreciate that the F&R committee doesn't feel like they met their objectives, but the information that we have is that the main deliverables of that committee are the revenue proposal, which we have, and then a lot of information about how to move forward. So,
okay, I'm not gonna belabor it. I just wanted to kind of bring it up that it was a concern that there were quite a few things that were brought up that said we didn't do.
Yeah.
And so when it said they will be met, I just thought it would give that up. Okay. My only other one is on page 6. And that was something that I had said. It's the part about workers' comp and subrogation on the operations committee. And so we had board questions, discussion, suggestion to bifurcate workers' compensation. So medical costs go to UHPGB, whatever. Yes, indeed, but I also meant to say, and if I didn't say, that it would also be that basically that the funding would come over. It wasn't just that we kind of start sending our things back and forth. I'm really looking for administrative simplification, and I'd like to have us explore the real issue of SAFE and whether we could honestly just take the medical portion of SAFE into
Right.
the board kind of thing. So I don't know that it just didn't quite say it what I meant to say. So I guess
Yeah.
I'm saying it now.
So I think it's a really interesting point and important thing for us to consider, and maybe it will come up again. The purpose of the minutes, of course, is to record what was said and not what you
Right.
intended to say. So I
I'm not
need to
sure.
defer to, because Isabel has the recording
Yeah.
of that, so I need to, I don't know if you wanna, we can,
I don't
well,
want
how's this?
I don't want to stop approving the
Right, right.
minutes.
Right, of course, no, but I get it. But maybe what we can suggest is that we just take a second listen to that recording and make sure the minutes reflect what was actually said on that topic, if you don't mind. Okay, so we can do that.
Okay.
Take a
Not
second
now.
listen. No, not now.
Okay, all right.
Have,
good.
no, because Isabel
Yeah.
listens to the recording and
Right.
that's how she, yeah. So we'll have
Yeah.
her do that. And then anything else?
Nope.
Um,
There were these little left out a letter here and there, and I told those to Isabel, so.
Yeah.
So I'm ready to go.
In the minutes about the transition committee formation, the board members selected were not
Oh,
mentioned
Okay.
specifically. And I think that is relevant.
okay. That
So
was
it
it.
says that the transition committee was established, but doesn't name who was appointed to those, nor the committee
Members.
members, so.
That would be
Yeah.
good.
Okay, so would someone like to make a motion to approve the minutes with the edits of a second look at the piece about SAFE that Mary Lou was talking about, and with the addition of the named board members and committee members for the transition committee?
I'll make that motion. Second.
Great. Any further discussion about that? Great, let's do a roll call.
Helen Belanca,
Yes.
Chun Wei Chi,
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
Thank you.
Great. Thank you, Mary Lou. So in addition to Isabel's amazing job taking the minutes, it helps to have somebody scan through them and make sure they're
And
accurate.
it's not my usual strength.
So thank you to both of you for that. Okay. Next, we'll move on to public comment. I'll start with the written public comment we received this month. Again, I'm gonna beg the public's forgiveness for my mispronunciation of your name. I'm sorry. So I think it's Mikhail Dunlap wrote in with questions about our behavioral health proposal and wondering how billing would occur. Tom Sinsick wrote with a reminder that Oregonians had a constitutional right to affordable health care, and that by necessity involves single payer. Lou Sininger wrote advising us that in the case of workers' compensation, the UHP should cover medical expenses instead of being reimbursed by SAFE or other insurers. We have a letter in our public comment from an organization called Oregon's Healthcare Future Action, which looks to me like a local iteration of a national group called Partnership for America's Healthcare Future Action. They describe themselves as a coalition of health insurers, hospitals, and businesses strongly opposed to government-controlled healthcare models. And they believe in strengthening what is already working in our current system. Leon Bote wrote to oppose our decision to separate long-term services and supports payment from the UHP. As a reminder, all long-term services and supports will still be covered, but our recommendation is that they be administered and paid for through Department of Human Services and not through the Universal Health Plan, in case there's any misunderstanding about that. Todd Ferris wrote in with 129 co-signers with concerns that Milliman's cost estimate is not accurate because it's based on the status quo and doesn't account for administrative savings with single payer. They submitted a second piece of testimony with links to articles and studies showing estimates of cost savings. I read every single one of them. And I will say that this is going to be a pretty big topic on our agenda today, so we will be covering that. Great, and that's all the written comments. And now we'll pass it to Mimi for our executive director's report. Oh, sorry, I apologize. I didn't mention this, but we have testimony, oral testimony signed up, but nobody has signed up for testimony on the voting topic. So I just want to clarify and confirm that nobody's wanting to testify on that. And we'll save those for the end. Great, thanks.
All right, thanks everyone. Good morning. Thanks for being here. I'm Dr. Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. So just giving a brief update. One thing for people to know, DCBS is doing a lot of work on their website regarding accessibility, which their team is really working very, very hard. And so it is causing a little bit of delay from the time when our work is ready to be posted and when they're able to post it. So please just have a little grace because they are working hard. We are not in control of when things actually get posted. Next, however, excitingly, our transition committee has its own landing page on our website. So that's exciting. That's where you can get your transition committee meeting places to sign up to join the meeting. So also exciting. There is a lot of board outreach happening. There are the HCAO town halls, and I'm going to leave it to our CECC committee chairs to talk about that information. I will say I had the opportunity to talk with Mid-Valley Healthcare Associates. I was joined, Dr. Tonway T was there as well, and we had some other people who are very familiar with our work, and that was excellent. And actually next week, I'll be presenting on the Universal Health Plan Governance Board for the Washington State Bar Association. They're giving actually a CLE on healthcare as a human right, and they were interested. They have sort of high-level overview, and they're interested in learning how things are working in Oregon to move that forward. So, all right, we're going to move right into the budget. This is just the general budget. We're still doing moderately well. You can see on the bottom right-hand corner is really the one that you want to look at to make sure that there aren't parentheses around that number. There are parentheses, that means we are in trouble, but we are not. So we are on the good side again. This is our budget through the end of the biennium, June 30th of 2027, and we are holding our own, I will say. Also holding our own with our consultant groups. We are getting close to their limits, but everything is as expected with this. So we anticipate that they will all get to their not to exceed by the end of their contract's time. And we're grateful for all their work. All right, I'm going to speak briefly about some of the work that we are doing in anticipation of the 2027-2029 biennium. And this is a policy option package is something that we are creating with the help of our associate at DCBS. So policy option package proposal to change the level of service or funding sources for activities authorized by the legislature. Now, currently there is funding for the Universal Health Plan Governance Board through June 30th of 2027. There is no funding that would come from any other source than the general fund. So a policy option package is needed if you want to have any increased funding for additional changes. It's a little bit, we're a little bit different that we're not a typical department within an agency, and we're completely funded different than other DCBS, but we're doing this work and we just want to make sure that the board was aware of it. Policy option package has to meet approval, as I mentioned, at multiple levels. So the agency has to agree, yes, this is reasonable. The governor's office needs to agree, yes, this is reasonable. Then, of course, the legislative branch has to agree, yes, this is reasonable. So what so far is included in the 2027-2029 POP, in addition to what I would call the status quo. So essentially the budget that has been proposed for the past two biennium, you know, with changes related to inflation, et cetera. In addition to those funds, funding for a statewide engagement campaign, a large IT professional services contract, statewide economic forecasting, which, as you all may remember, we had to remove that from the Milliman contract just because of budget issues and timing, and then an additional policy advisor. I have already gotten feedback. Thank you so much, Mike, with his ideas. I think what I've said right now, this is a little bit of a placeholder, because of course there will presumably be legislation later that may have some changes in this, but I think this is going to be an important discussion, either, certainly at the board, potentially with some of the transition committee of what people see happening in the 2027, 2029 biennium. So, I'm going to propose at the next either board meeting or how the best time to do it, that we have a more detailed discussion about this, but just so people are aware of the process is going forward. Yes.
When is your pop due? Because I know at OHA, they've told us like it's due April 1st, something like that.
Yes, it is sort of a fluid deadline, I would say. So an initial one has been turned in. So it's kind of, it goes through different levels of review. So we've turned in the initial one that is due to the agency, to DCBS, and then we're awaiting feedback from them. And then I think it is true though. It is not due in September. It is due in April. So we're continuing to work on it.
Okay. Does that mean you had to put dollar figures in on this thing?
Mhm.
So what did your total? come up with?
I don't have that slide up
Okay.
right now, but I'll bring it forward. Mhm.
I was gonna ask a similar thing, but also just to clarify, so our current budget is 1.9 million per biennium.
Okay.
And so that funding is not part of the POP.
Correct. It would
Okay.
be, yes, it would, this POP is on top of that.
Right, so that baseline funding is sort of a separate issue that we still would need to sort of get approval for, because we get funding from the general fund into the agency budget. So that piece is still, that's one issue that we would need in terms of continuing our work, and then this POP would be funding on top of that 1.9 billion, but to do the work that would move this effort forward.
Correct.
Right, so yeah, so there's two pieces that we need to get approved, right? Our base funding and then
Yes,
the POP.
yes, absolutely.
Yeah, which neither of them are by any means sure.
Correct.
Okay,
And so the base funding all of this. When you look at the organizational chart of DCBS, because we hang out over here.
Correct.
And so,
Yes.
so all of this goes through when DCBS is putting their big packages through.
Yes, but no funding comes via DCBS.
No,
Just to be
no,
clear,
but
it all
it-
comes
but
from the
it
general
goes
fund, but yes,
into
we are
Request.
sort of,
I mean, we're kind of a little odd.
yes,
And when
exactly.
you look at the DCBS budget, when I did the last time, we are the only general fund.
Yeah.
In that whole budget. So they aren't quite used to this either. So.
They're very helpful and
Yes.
very,
Yep, but learning too.
okay. Any other questions? Mike?
Oh, just and I'd like maybe some way to think about this. I just gave comments to Mimi of kinds of skills that I think we're going to need in much more depth. I am blown away by the competency of our current staff. Having said that, a chief financial analyst, there are a number, something for beginning to get into contract negotiations and like are things I anticipate, right, will be necessary. And it's based on, Singapore, Taiwan, a number of places have had to, if you don't do that, you then wind up using consultants. And the game is you use consultants and everybody argues about the stuff from the consultants. At some point, I think Oregon would be wise to do a little bit more investment in the core staff and not just rely on consultants and us harried volunteers.
Just related to Mike's comment, last month after the meeting, one gentleman participated online on our meeting, wrote to me saying he's an actuarialist. I think I forwarded that to you, and he's willing to volunteer for us. So I will maybe connect you with him.
Great.
Yeah, he's willing to do volunteer for us.
An actuarial person.
Yeah, actuarialist.
Okay.
And maybe we should get one of your students as well.
great. Anything else for Mimi? Okay. Then let's move on to the OHA readiness report. I believe we have Jessica Marino joining us today. Welcome, Jessica.
Jessica, do you want to share your screen or would you like me to share what you sent us?
Thanks, Mimi. I would love it if you could share, if that's all right.
All right, let me go. Okay, everyone have a little grace. Just give a moment because Isabel's computer isn't working and you have me manning all of this. So talk amongst yourselves for just a moment. All right, looks like we're ready to go.
Yeah, thank you, Mimi. Appreciate it. So good morning, everybody. I'm Jessica Marino. I am with the Oregon Health Authority, and I'm here this morning. I think I've got about 10 minutes in the agenda to give an update on OHA's second and final deliverable related to this body of work, and that is our system readiness report. That report is still being developed. It's in the draft form. We haven't shared anything with you to date, other than these slides. So this is really just a sneak preview for me to set the stage, kind of what we're thinking, and hear some early feedback and thoughts from you all. And just to set the stage with the legislation and how OHA is named. 1089 from 2023 requires the board to engage OHA in two matters. One is federal authorities that could be needed to implement a universal health plan, and that deliverable was shared with you all initially in October and finalized in December. And then second, to engage OHA in determining how our agency's existing systems will integrate with the universal health plan. And so that's really what I'm talking about today, that second deliverable. And there's two things that I want to highlight at this stage. One is, oh, sorry, Mimi, back to that last slide.
Sorry.
I'll cue you for the next slide if that works. So when we're talking about Universal Health Plan, that bolded text, we're talking about the plan that was put forth by the Joint Task Force in their recommendation report. And we're also talking about any guidance from SB 1089 in terms of what the plan should consist of. And that's because, as you all know, the board is still developing its version of the plan, its final recommendations. And then second, this is a bit in the realm of semantics. While the legislation does use the term how systems will integrate, OHA has been thinking about this work more conditionally. And so in our report, we're really using the term could integrate as opposed to will. And that's because there's a lot of pieces, a lot of implementation considerations that would need to get sorted out, including legislative direction for OHA to engage in any sort of system integration work. Next slide, please. So this is sort of a high-level overview of the purpose or the goal, what we're trying to accomplish with this deliverable. First things first, we wanted to begin with a landscape analysis and look into really what OHA's current systems are as they relate to healthcare oversight and operational implementation. And so we wanted to look into OHA's kind of operating environment, key entities, key partners, programs, etc., everything that makes up the status quo. And obviously that is a really big order. OHA is a massive agency, so we could not look into every nook and cranny. And how we approach that, I'll get into on a later slide. Second, we decided to look into existing kind of resources and systems that would likely be involved in a transition, and what that transition would look like for those systems if OHA were directed to make that transition to a universal health plan in the future. And when I say resources, we have an asterisk there because I want to underscore that we weren't doing a financial analysis. When we're looking at resources, we're talking mostly about staffing and systems. And again, thinking about it in a conditional sense, what resources could be needed to make that transition possible. And then finally, we wanted this deliverable to be like really a tool or a framework for how ongoing readiness assessments could take place in the future. And that's because, as I mentioned, the task force made a recommendation. The board is working to refine and improve and expand upon that recommendation. And this work is going to continue. There's potentially going to be feedback from the legislature requesting changes, and we want this deliverable to be a tool that can be adaptive to how this work is going to continue to evolve over the years. And then I want to highlight this assumption at the bottom of the slide. So per the Joint Task Force report and per SB 1089, we kind of made the assumption that OHA is going to be involved in an integration with the Universal Health Plan. Now, that is a bit of an assumption, and it is, the board's duty to kind of make whatever recommendation you choose, regardless of how that involves OHA. But for the purposes of this deliverable, based on those preliminary documents of the Joint Task Force report in 1089, we are assuming that OHA will be involved in an integration for a universal health plan. All right, next slide, please. Okay, so now I'm going to get a little bit more into the substance of this deliverable. So this visual might look familiar to some of you. This is adapted from a Congressional Budget Office visual that was used in the Joint Task Force report. And it is a visual on the core components of a universal health plan. We tweaked this visual to add some components that were not part of the original, such as equity. We think equity is a core piece of a universal health plan, so we wanted that to have its own component named up front and center. We also added governance to this chart, kind of the overall structure, the overall governing piece of a universal health plan. So this visual, these 11, I believe, components really provided the framework for how we dove into OHA as a system and provided analysis of what it currently looks like and how it could adapt in a transition to a universal health plan. Yeah, I think that's all I'm going to say on this slide. Next slide, please. So within each of those 11 components, we've decided to do the following. One, provide a definition of what that component is. What is equity? What is universal health plan governance, for example? Two, share what the Joint Task Force recommended as it relates to those components. And the Joint Task Force, as you all know, did a lot of work. So for almost all of these components, we have some great recommendations to build off of and to analyze. Three, we mentioned any parameters from SB 1089. As you know, 1089 didn't give a ton of detail into the actual substance of a universal health plan, so there's not a ton of content there, but we did want to highlight any sort of direction or parameters that comes from 1089. Four, we went into that landscape analysis. So what does this current component look like today? And then five, the readiness assessment piece. What would it look like for OHA's systems for each of those components to rescale? And, I mentioned it's tricky to figure out how broad, how narrow, how detailed to get when we're talking about such a big system. And for some sort of theoretical guidance, we leaned on Paul Farmer, who some of you may know, a physician and anthropologist. He has this concept of the 5 S's of healthcare delivery, and they are staff, systems, stuff. So like the actual equipment, space, the buildings, and social supports. So we kind of approached each of these components with each of these 5 kind of categories of stuff, system, space that exists within them. Next slide, please. And I'm nearing the end of my deck here. So in addition to giving that analysis of each of those 11 components, we wanted to provide some implementation considerations. These are the coulds that make a lot of this work conditional. So these are enabling policy, a ballot measure, federal authorities, the wind down of existing programs, and HR1. So we're planning on having a whole section of the report that dives into each of these in depth. Next slide, please. And finally, my last slide is just what's kind of coming up next for this report and where we are. So throughout the rest of this month, my team and I are continuing to engage with subject matter experts across OHA. So far, we've had over 50, I believe, people involved, weighing in, bringing in their expertise. And we're going to be wrapping that up at the end of this month. And then on April 9th, sharing a draft of the report with you all. That is 1 week before your April 16th board meeting. So the idea is for you to give that a read. It is going to be long, I will warn you. I think it's currently about 37 pages. So I encourage you to set aside time if you want to give it a thorough read. There is a nice introduction and conclusion that will give some high-level takeaways if you're not able to dive in, or if there's a particular component that you really want to hone in on. You could sort of think of it as like a book and just pick a chapter. And then I'll be attending your April 16th board meeting to talk it out if there is any questions or comments or ideas that come out of your read. And then our plan is to finalize that report and send it off to you all by the end of April. So that is my spiel. Happy to take any questions or comments.
Jessica, this is Helen. I'm a little surprised to hear that the report is being based off the Joint Task Force recommendations, because while that was a really beautiful body of work and certainly got us started, this board has spent 2 years really expanding and detailing much more, many more of the components of a universal health plan. I appreciate that none of that's been finalized, and certainly it's, not collated in a way that's usable, but we are working on we have a sort of a summary of all the decisions that we have made. And there's quite a bit in there about what the administrative structure specifically would look like of a universal health plan. I specifically, and I assume other board members would agree with me, we'd really like to see this report focus more on the decisions this board has made rather than the decision that the Joint Task Force has made. And again, I realize that, that's been information that would be hard for you to access up till now, but if we got you a document that summarized those decisions and kind of laid out sort of where we feel this is going, would you be able to sort of make sure that the decisions of this board were incorporated into your plan?
Thank you so much for that question and suggestion, Helen. Yeah, this was a topic of debate for our team for quite a while, wanting to be as responsive to the work that you're doing as we possibly can, and also being aware of the fact that decisions aren't final yet, that you are soon going to be getting the final proposals from all the committees and initiating the reconciliation process, and having your final proposal done in a couple months from now. And part of the reason why we took this approach is because our work on the OHA side is winding down at the end of April. As you may recall from our presentation back in October, the funding for my position, Danielle's position, is ending at the end of this month. And so we were faced with the tough decision of how to handle this body work with this truncated timeline. And so opted for the Joint Task Force approach. But it is, I really appreciate your suggestion, Helen, of you all putting together a document that highlights some of the decisions that have really been landed and that are not going to be up for reconciliation. And I think we can, I'd say if you want to get that together and share it with me as soon as possible, we can do our best to incorporate those elements.
I'm going to look to Mimi and Lee. Do you think we can get OHA some information that they can?
Absolutely.
Okay, that would be great. I know there's a number of other questions in the room. I think, Mike, you had your hand up first.
Thank you. And Jessica, thank you for your report. This afternoon, we're going to start Dr. Richardson and I and others in the room, we're going to start our transition committee So, but I'm going to ask you a very fundamental question that we will be wrestling with, and that is, what is the scope of an information system in Oregon, right? And it seems to me that you could take a very narrow approach within the universal health plan and just look at what does the universal health plan need, or you could take a broader look in terms of scope of how this further enables the providers to in fact make healthcare more affordable. Or you could the third approach is to have the universal health plan, the health system, and Oregonians. And I think where technology is certainly going in Oregon is more and more people are trying to get access and use healthcare information. My fundamental question to you is, when you do this report, which of those three parameters are you going to be looking at? Because I for one, think we should be looking at all three. We have not made that as but any decision, but we would have to do this in partnership with you and others. So, do you have any thoughts about that?
I do. Thank you for that question. So, a couple things. Mimi, if you want to go back to slide 4, which shows the visual of all the different components. Yep, right there. So, so technology, as you mentioned, is not kind of its own core component, but it does touch basically every single one of these. And so we plan on touching on the technological infrastructure, expertise, as it relates to basically every single one of these. And you'll see that will kind of be patient experience, it'll be provider experience. And to that end, in this report, OHA is not giving like recommendations on how we think technology should be integrated in a particular component here. However, what we are doing is laying out what current systems exist, what software, what infrastructure currently exists, and what has the capacity likely to be rescaled to the level of doing it statewide. But we're not doing kind of recommendations of we think this iOS system should prioritize patient experience over provider experience. Rather, we're laying out here's kind of a current system that we have, here's what it does, and here's what it could look like, what additional resources, staffing, et cetera, it would need to do this on a different scale.
If I could just follow that up. So I definitely get what you're saying there. However, I've been doing stuff here in Oregon a long time, and the joint task force work was done during a certain era. Since that time, there are a couple of technological things, right? I mean, AI was a theory then. Now it's becoming ubiquitous. Epic now is the dominant provider in the state, and we have a fundamental political issue as a state to deal with, and that is, if you're going to use something and there's an area that already has 80% of the major systems in the state, it'd be kind of ridiculous to state just theoretical. And I mean, the practical thing is, what are we going to do, and what are we going to learn from other states, if you will, and other countries about how one could most affordably develop technology. So I would offer that I would love for maybe a couple of us could have conversations with your folks to at least share some of our thinking. I think we need some level of dialogue or input before you do your final report, because I want to make sure we're targeting the right target.
Yeah, thanks for that follow-up, and I'll defer to Helen and Mimi for this, but perhaps a next step could be including some of those technological pieces in this summary that you're going to prepare for us.
Thank you.
Yeah, so I just was wondering, and I don't know if this is a Mimi, Helen, or Jessica question, but since their time, OHA's time supporting her work in this way is wrapping up in April, what
are there conversations about going forward? Like, or is that just like a one and done? You know what I mean? I just understanding, we're gonna need deeper and deeper,
So I can answer
Yeah.
that. So I would say that, the time that has been allocated for OHA support in our current budget was from the past biennium. And so it's done until June of 2027, which is when this current budget is done.
okay,
If and when we need more support or more protected time, I would say, from OHA, we would have to include that in our 2027-2029 budget that we were talking about earlier, and we
Okay.
could request that.
and
as
is that
part of
something else that we would put in the plan, potentially,
Put in the plan for
the plan we're creating?
The
to give to
PLD, I think is
legislature?
what you're talking about. Mhm.
the budget.
The specific, like, how we would be working with, how we propose that we would want to work with OHA.
Right.
And on the same note, since we, it sounds like, are not focusing on long-term services and supports now, that means we're gonna need some level of analysis and integration and conversations with ODHS, ODDS,
Yes,
and aging,
right. Thank you for
facilities.
bringing that up. That was one of my questions for Jessica too. Jessica, even in the joint task force, they said that long-term services and supports would not be covered for folks who were not otherwise eligible for OHP. And that would transition. So in our discussions from months ago, we talked about transitioning the coverage of long-term services and supports purely to DHS, because right now I know it's sort of a joint partnership. Is there going to be some mention of administratively how that would work in your report?
Yeah, thank you, Helen. And I'll respond to your question as well, Amy, just build off of what Helen said. So, taking that first, in addition to what Helen said about the budget, even though the funding for my position and Danielle Ross's position is ending, this is still like a body of work that involves OHA, obviously, and we have like core staff that will be able to, continue to track the work of the board, and be able to respond to questions as they come up. Now, with regard to LTSS, and I probably should have said this earlier on, like we are still closely tracking the work of the board. We're attending meetings, we're watching what the committees are doing. So we do know what have been large discussions and big priorities. And we know LTSS is one of them. And even though that was not called out in the same way with the task force report, we have heard your conversations. And so we do have a plan to talk about LTSS. And it does, as you said, it is largely held by ODHS. And when it comes to ODHS's role, we can't offer commentary on that, but we can direct folks to ODHS and say, here's kind of here's where you would want to go to find out more information about how ODHS is doing this work.
And just from speaking from lived experience of a parent who has to navigate those two systems and how they don't talk to each other when it comes to OHP re-enrollments and not really recognizing when somebody is disabled and those things. Hopefully we can continue to improve even before that, but like, let's not make that worse. And that's why I think it's important to, even though we're saying we're putting it kind of to the side, our ODHS, what we heard from our disabled public folks that have given comment is it can't be an afterthought. So it needs to be like thought about all the way along.
Go ahead, Jonathan.
Thank you for Jessica for your presentation. I have a more broad system policy question that I don't think we can expect to get an answer today, but it needs a lot more discussion and exploration. So this broader question, and I hope the OHA can explore, that is, most countries with universal healthcare system, they integrate their population health promotion with the healthcare delivery very smoothly. So my broader policy question is how and whether OHA is exploring this, how will we, when we implement the universal healthcare, how will we integrate the population health promotion with the healthcare delivery? For example, how should we set health priority? how shall we set healthcare priority? So when, for example, when there's a new drug, new procedure available, how do we decide whether are we going to cover that or not? So these are important system-wide policy to consider. And then I have a brief comment about health information technology. What we envision, again, for most countries with universal healthcare, they have a platform that's integrating for the information for both providers and the population. For the population, they have access to all their health data, health information. For the provider, they also have access to patients' health record, as well as whether the patient has duplicative prescription or diagnostic procedure, et cetera. So that's the kind of health information system we hope. And that can also serve as a public health education platform that can be all integrated in one platform that we hope in the future we can develop that.
Yeah, thank you, Chunwei. And yeah, those are excellent points. I wish we had the bandwidth to kind of take this broader than what is outlined in our scope. And unfortunately, we don't. We're really just sticking with what we've been charged with, which is being engaged on matters as it relates to the Universal Health Plan. And to my knowledge, based on what the task force put together and SB 1089, there isn't a recommendation to date on population health. And I know that this has come up in your conversations, so I do have an ear to it. But without kind of a more concrete recommendation, it's not something that we're able to kind of really do analysis on at this stage.
I just was gonna say from my years in public health that the part of OHA, which is the public health piece, is very tiny. And I heard the other day, I've got budget number that the total amount of money for this biennium for state and local public health is $115 billion for the biennium. We're talking billions here. I mean, we're talking 115 million. It's just, I don't even call it decimal dust at this moment. And so I do think that this needs to be really looked at and a strong recommendation. And I have talked to some of the public health people about, do they want us to kind of put it in with us, this, and they absolutely do. So just thought I would mention it's really a very small piece, Chunwei, that Oregon does and has for all my lifetime totally underfunded it and not really included it in medical care. That's the thing.
Mimi, I'm wondering if we can make a note that as we think about the work in 2027, 2029, that we dedicate some staff time, some space to really exploring this more. I think that's a great place to take this next. It's a really important point, and I don't want us to lose it, but we just put a bookmark and put that as part of our task moving forward.
Already there.
Judy, did you have something?
It was about public health.
Okay. Okay. So this slide that's up on the on the screen right now, Jessica, when you're talking about the components of a universal health plan, obviously the administrative structure of the universal health plan will be a public corporation who will take over many of these functions. I assume that, when you're talking about these components, there'll be some comment on the legal relationship, the logistical relationship, the financial relationship between OHA and this public corporation. Is that accurate?
Yes.
And then I have one more question. Obviously, the massive effort of OHA in the past decade, more than a decade, has been CCOs. And I know there have been a tremendous amount of learning from the CCO experience. Can you just comment on how one of my sort of real puzzles of this whole equation has been, how does Oregon as a state move from this model of the CCOs, which have had a lot of successes and a lot of setbacks? How do we use the experience of CCOs to inform the universal health plan? What are the learnings? What are the things that we definitely should hold on to with the CCO model? And what are the things that need to fall away? Can you say anything about that?
Yeah, I can, and that's such a great question, and it's honestly really an interesting question, Helen, and I think it gets to it really gets to how we approach this deliverable, and we really thought about it in terms of the large health systems that currently exist. CCO model, we have the marketplace, we have private insurance, we have PEBOWeb, and there's large systems that have been established and running for years related to each of these. And there's basically an argument for using any one of those as the main model for a universal health plan moving forward. And talking with our various subject matter experts across the agency, people have made really excellent cases about why marketplace should be used as the foundation for a universal health plan, why the CCO model should be used. And our goal with this deliverable is to really lay out what those different markets look like so that you all can decide what you think the best approach should be. Look at what those learnings are, what those existing structures are for CCO, compare it to what it looks like currently for PEB, and make your recommendation on kind of whether we should be adopting and reskilling one of these models or building something entirely anew, looking for a combination, etc.
I appreciate that, but I think OHA is obviously in a really unique position to advise us on the learnings from CCOs.
From the transformation center.
And the transformation center is a great point, and what worked well about those and what didn't. And so while I appreciate that deference, I think being as specific as you can be about the elements of the CCO model that are worth preserving would be really helpful to us.
Yeah, it's a little bit sticky because we're not really making any kind of recommendations in this report, and we're wanting to let that sit with the board. However, we're doing our best to really lay out kind of what is working and what we currently have so that you can make an informed recommendation.
Great. Did you have something?
No, I was just,
Okay.
for in the future, we will
Okay.
want to get lessons learned from the transformation center.
Totally. Any other questions for Jessica? Jessica, thank you so much for your time today for this presentation. Please extend our gratitude also to Danielle and to Laurel. We really appreciate the work that you're putting into this, and we look forward to your report, and we will commit to getting you a summary of some key decisions that we hope you can consider very soon.
Great. Thanks for your time. Thanks for the excellent questions. I'll be in touch.
Thanks, Jessica.
Okay, so moving on, our next topic is regarding the economic considerations of a universal health plan. We are very pleased to welcome Dr. John McConnell. He's a health economist, a professor and director of the Center for Health Systems Effectiveness at OHSU. He has worked as a researcher, evaluator, and advisor in Oregon for more than 20 years. And he's been really gracious to take some time today to come and review our plans to date, our thought processes, our decisions, and give us his take on it. So welcome, Dr. McConnell.
Yeah, thanks everyone. Nice to be here. Can you hear me okay?
Yes.
Okay,
Yes,
and
we
so
can.
and then I'm running the slides, is that right?
If you would like to, or I can share from my end.
Okay, let me try and do it here. Let's see. Does that look okay?
Yep, that looks great.
Okay, great. All right. I want to run through a few slides that are going to be familiar territory to many of you, but just use that to set the table, and some of these data might be new or different ways of looking at it. Most of you know that when it comes to healthcare spending, the US is an outlier. What this graph shows is that we would expect that as countries get richer, as their GDP per capita goes up, that's the horizontal axis, that they would spend more on healthcare, and that's the general pattern. But healthcare spending per capita is the vertical axis, and the US has always been an outlier and continued to be an outlier there. Spending in the US has just risen relentlessly year after year after year, with occasional slowdowns here and there, but the trend over time has been to go up continually. You can see here, this is total spending per capita, and then adjusted in 2023 dollars, slight dips near COVID, but otherwise kind of continuing to go up. It's really gone up a lot recently in the last year or two. Another way of thinking about this is the percent of total GDP that we spend, so percent of all of our dollars that are spent. And so when I started in this field back in the early 2000s. There was this notion that it was a little bit over 12%, and people couldn't imagine what would happen when it hit 15%. Now we're kind of heading towards 20%. This is spending increases risen across all payer types, but especially in private insurance. So you can see the difference here with the starting baseline in 2008 and how this has tended to go up over time. Gone up much more in the privately insured than in Medicare, and Medicare more than Medicaid. Why does it keep going up? Economists usually point to a few things. New technologies is one that economists are really focused on that gets probably less attention in the press, but this has a really important role. New technologies is a broad term of capturing all of the new things that we can do in healthcare. This could be imaging, biologics, new procedures, new therapies. Many of these can increase the quality of life or reduce suffering, but they do, as you introduce these, they tend to cost more money and add on to our premiums. High prices, especially in the commercial market. We see a lot of increased high prices coming from market power. Recently, most recent data, also some increases in utilization, which is a little bit new. Market power and lack of competition pushes prices up. Administrative complexity, we have lots of different payers, lots of different people who are adding in little bits of time and effort to try to get the payment submitted and get paid for what they're doing. And then an aging population, which is real, but maybe smaller than maybe people think. Affordable Care Act helped with coverage, but didn't solve everything. And so really this was the kind of mostly about coverage and not so much about spending. We can see a big increase in the number of people who are covered by insurance in 2014 when the insurance exchanges opened up and Medicaid expansion went in place. So nationally, we have relatively few people uninsured compared to where we were before. Oregon has really been very strong in this area, and so we've reduced our uninsurance rate by more than most states, but also puts us at risk. Many of the changes that are coming from HR 1, the recent legislation that passed, are going to cut Medicaid implicitly or kind of in as a byproduct of new policies like work requirements that are going to end up having people leave the program. So things are going to change more in Oregon than in other states proportionally. Most of you know that coverage is not equal to affordability here. So here's some relatively recent data. People saying whether they've skipped or postponed getting healthcare they needed because of the cost. You can see those. And this reminds me that I think before I should have done a little bit more of an introduction of myself, but this is a good reminder here. So let me pause this slide and talk a little bit about my own development here. So I'm a health economist. I've been in Oregon since doing this type of work since 2002. And so I've seen the evolution of this. And I would say that that I was a kind of maybe a single payer skeptic going back 10 or 15 years ago, or a universal healthcare coverage skeptic. It just seemed very challenging. I think I was encouraged by some of what was being proposed as in the Affordable Care Act because I saw it as politically viable. But I think I've really come around to feeling like that kind of incremental hybrid system is just not working. And I think a lot of that centers around the affordability issue. And so we know it's unaffordable when you are uninsured, but I think even for people who have insurance coverage, that it's really feeling unsustainable. And so I watched the younger kids who are sort of struggling to figure out what their job looks like and whether or not they can get Medicaid, and if they can get Medicaid, what it looks like to get a provider. Lots of people that I know have commercial insurance, but are still shocked by how much they're paying out of pocket. Providers are exhausted, and so I've sort of come to some sense that what we have is not working. And so so I think sorry that I didn't do that introduction in the beginning, but wanted to sort of kind of give you some perspective on how I look at this and how important I think affordability is when we think about these things. Onward. So employer-sponsored insurance, what people are actually paying is often hidden. So, we often look at our benefits when it comes around, and we see what we have to pay, and we look at it. Maybe we notice it on our monthly paycheck. But employers are covering a lot of that, and we don't always understand that. So in Oregon, 2024, The cost of a annual family premium was about $24,000. That's a lot of money that your employer is paying that, but it's coming out of your wages. That's roughly equivalent to carrying a monthly mortgage on a $400,000 house every year, but you're not building any equity. You're just sort of using that to pay for your insurance. And then, of course, there's co-payments and deductibles and other things that come into play there. This is really a hidden tax, and so economists and others, when they look at how this is paid, even if the employer is picking up a large share of it, it's coming out of your total compensation package. And so this has really had a dampening effect on wages. And so it's expected that that by 2019, that families have lost $9,000 in wages associated with healthcare premium increases. You can think that this probably disproportionately hits people with lower or middle incomes, right? So their incomes, if it's $50,000 a year or $60,000 a year, that cut on their wages is going to be felt much more significantly than people who might have incomes that are 2 or 3 times that. Unfortunately, we're doing all this spending, but we're not having great success, at least in terms of life expectancy. Life expectancy generally has gone up and up and up, which has been good news going back. You can see back here in 1990, we weren't doing as great as some of our peer nations, but that gap has spread even more. Some of this in the kind of the 2010 to 2020 era has kind of gotten some been called the deaths of despair, and because this is the first time in the nation's history that life expectancy actually declined. Some of that is attributed to suicides, drug overdoses, deaths like that. There's also a big split along college degree lines, and so this is sort of, people call this the BA split. And so people with a bachelor's degree, their life expectancy has tended to go up, and those without a bachelor's degree, that's where the life expectancy has decreased. When we teach health policy, we talk about the 3-legged stool. And so the joke is, do you want affordability? Do you want coverage? Do you want quality and access? You can pick 2, but you can't have all 3. This is the first time in my time in Oregon and looking at these that all 3 of these feel like they're not attainable. And so the system really does feel very different to me now than it did 10 years ago when we were making this joke. Everything seems expensive. Access seems very difficult. There's issues with quality, and now we're facing some coverage challenges coming from the federal legislation. So I think in some ways this does create an opportunity. So the system that we're in Oregon is really facing, I think, a unique or unprecedented set of challenges. You've heard about these in different ways. Hospitals and CCOs are struggling financially. Providers are burned out. I'm really kind of shocked when I sit for a while and talk to the physicians at OHSU, just what it's like there. It's very different now than it was 10 years ago. Insurance increases are unsustainable. So the small group insurance rates this year, the average increase was 11.5%. Providence was up by 21%. Just to remind you how these things work in terms of increases, that's equivalent to doubling your cost of health insurance every 3 years. If that was sustainable. The marketplace subsidies are a mess. So this is again coming from issues with the federal government, lack of subsidies. Premiums are doubling for some families. Also, I think patients can't get the care that they need. Jane Zhu is a physician researcher that I work with at OHSU who does a lot of work on Medicaid and on access and coverage. And she has a new paper that just came out last week. They called 444 clinics across 4 states to see if they were taking new Medicare patients. And so across those 4 cities, sorry, I don't know if I said states, across those 4 cities, you can see what the rates were of clinics taking new patients. LA quite high, so you're in good shape. If you're in LA, 97%, Chicago, 93%, New York, 82%. Portland was an incredible outlier. So only 35% of the clinics that they called were taking new patients. So we have a real primary care shortage here in Oregon, or at least in Portland. You might feel it, you might hear about it, it might seem anecdotal, but it is actually quite real, and Portland is a real outlier. I think there's also change in consumer sentiment around this. And so this is a graph showing whether or not people felt like that the federal government should guarantee people have health coverage. You can see that was quite high leading into Obamacare, then maybe some decrease in that sentiment with some dissatisfaction on how that rolled out. But again, it's coming back up. And so you can see it's about 64% here in 2025. I also think that there's an opportunity here to really frame what you're trying to do as a response to what's going to happen with AI. AI is creating an incredible amount of uncertainty. I think probably everybody here feels it in one way or another. This is a chart that suggests, which are the employment categories that are going to get hit most by AI. And a lot of these are sort of so-called white collar jobs. And so I think everybody who's sort of looking at this is probably kind of wondering, in this great uncertainty, what's their job going to look like and what's going to happen here. This suggests that there's going to be quite a lot of churn. And I think, one thing that would be, I think, highly attractive to many people who are looking at this would be knowing that regardless of what happens as they move in and out of jobs, or as AI changes their job, that their health insurance is not tied to their employer. There's a lot of reasons why single payer could be better. I think you all know these. I think these are a list of the ones that come to mind most immediately for me, and I'm not going to spend a lot of time on this. But I think there's a lot of opportunities here to improve on what we have. We have really a broken system. I think that's what I've been trying to kind of frame in lots of different ways and lots of different graphs here. I think there's a lot of reasons it could be hard. Here's a list of some that come to mind, and I want to touch on these, a few of these in more detail here. So I think one is, as I mentioned right now, we pay premiums. We don't see them so much. We can consider them almost a hidden tax. $24,000 in Oregon for our family premium. Single payer shifts this to very visible taxes, and even if the effect on the wallet is not the same, it's going to be visible. Create some clear winners and losers. So winners would be uninsured, underinsured, unstable jobs. Losers, maybe this is perceived losers, might be people with generous employer plans or higher incomes. There's a little bit of a tricky problem here in terms of the people who are most satisfied with the current system, maybe those with the most political power. And so here's some groups that might be satisfied with what they're doing, and might be less interested in moving to something that might change their care in ways that they're worried might not be quite as good as what they have right now. There's potential for economic disruption. We don't have good numbers on this, but on the insurance industry, maybe 3, 4, 5,000 jobs, maybe 6,000. This would be a group that I think would be concentrated and politically visible, and so these people are going to have an interest in what's happening here. I think there's a more diffuse group of people who are kind of doing some of the administrative work here. And if we cut out administrative, if we find a lot of savings on the administrative side, that also means some jobs around there that might be on the thousands. I'm not quite sure. But it's another group there that's going to be wondering, what happens to my job here. Hospitals are, quite fragile already, and I think, depends on what the future system looks like, but I think it's something worth noting. I think regardless of what happens here and how people express their concerns or what groups they're in here, we're really talking about a really unprecedented shift in how funds are distributed, and how that's managed is going to be really critical to the success of this going forward. I think abundance is kind of the key word. This is Ezra Klein's kind of way of framing things here. And I think it's important when we think about this. Universal coverage would work best when we've got high administrative capacity, trust in government, provider supply is adequate. I think Oregon is struggling with all of these issues. And so, it's one thing to think about in terms of, can we just turn the switch here, or do we need to think about what the state is going to look like when we turn the switch? I think Oregon's tax burden is also another challenge here. So single payer builds on an already high tax system. We don't have a sales tax in Oregon, but we're considered a high income tax state. There's some significant local taxes depending on where you're living. The new health taxes stack on top of those existing commitments. I think, depending on who you're talking to, I think there may be some concerns that recent efforts where we have raised taxes with interesting policy goals, that those have not been successes, that we haven't really sort of shown great competency in rolling these out in a real successful way. So I think a lot of people are concerned about behavioral health. Have we seen any progress here? This is one of the governor's priorities. Some of the local funds in the metro Multnomah County around housing supports, universal pre-K. We have, some of those funds are sort of sitting. We haven't really seen these deployed in the way that we might want to. So you may have a group here who's wondering, okay, this is one more type of policy that we want to do. What's the success rate been so far? Where can we find real successes? And they may be concerned about what they've seen in the past. And so this may be one challenge here. Concerns about in-migration, out-migration. So this is just, noting that what's been happening in Multnomah County is that people with higher incomes have been moving out. People with coming in have been lower income. And so that's, some shifts available incomes for what we could tax. And so I think, there are some mobility issues here that you might want to consider. I don't know exactly what the numbers are, but it's just, one more thing to consider. Again, I think as people think about this and they're trying to assess this, they may be challenged by so-called kitchen table issues. And I think, within Oregon and Portland, there are some issues around crime. So Portland has the 5th highest property crime rate of any city in the U.S., the highest commercial real estate vacancy. And so Big Pink is sort of iconic in Portland, sold for $370 million in 2015, sold for about 10% of that in 2025. I'm not a commercial property person, but when I talk to people who are kind of out there thinking about the health of the economy, they're very, very concerned about this. And they're very concerned that these issues are not getting more attention, that when they look at what city governments are doing and what the state government is doing, that this does not seem to be a priority. And so I think they're concerned about where the priorities are. Salem, experiencing similar things, high violent crime rising over the last 15 years. A few thoughts on the draft concepts. These are ones I got maybe a month or two ago. I'm not quite sure if they've been updated. These are very brief. I'm not an expert on these. The coverage pieces, I think, I'm trying to summarize what I see here in the black. This residency-based eligibility seemed conceptually clean. I think you'll want to make this as simple as possible. Some of the concerns in red here, perhaps no meaningful deterrent to strategic in-migration. Not sure if there's a long enough waiting period or limits tied to prior insurance. Maybe some loopholes for people who want to do medical tourism in Oregon. Primary care, I think, we've got a really great system of, how we frame primary care, and we've got a lot of experts in the state that look at this and have been thinking about this for a long time, desire to kind of increase the spending on primary care. One thing to caution here is that we should not assume that spending more on primary care will lead to offsets in more acute care. Hospital ED services, that's how we want it to be. And we often sort of think that that's what's going to happen, but there's not real strong evidence to support that. It might be something that kind of accrues over 10 years, but generally when we look at studies that, kind of, well, what if we see a big bump in primary care? Do we see changes in more acute care utilization within a year or two? We usually don't see those types of things. It could happen, but it's not something that I think we could bank on. Hospital global budgets here, I think there's a great evidence base here. This is sort of ramping up, slowly the amount that hospitals the amount of the global budget that would be hospitals would be subject to, starting off with about 30% of their revenues and then kind of going up. I think there's some real work here to do with federal alignment, rate setting authority, monitoring, and credibility. We had a healthcare cost benchmark that sounded quite good when it started. We hit COVID and a period of inflation, and that sort of wobbled and doesn't quite have the strength that maybe we thought it would 5 years ago or 10 years ago. Rural hospitals probably will require some special handling here. I think, concern here is that many hospitals are operating at or near negative margins. Moving to global budgets creates some new risks. Concern about, or question, I guess, do we need a buffer for readiness or resilience, not just based this on utilization, so that if we get something like COVID again, that hospitals have some space to move on this. Behavioral health, this is an area that I think a lot about here. I think this is really critical for the state. I think that I really liked some of the language in here, recognize the continuum of care, recognizing that coverage is not equal to access. We see that again and again in the data. Workforce, I think in facility capacity, those are big constraints, and I'm not sure that this offers a fix. That's one of the questions I have. I think, a broader population health piece that I wonder about is accountability. One of the things that we're looking at in our own study is this concept of so-called emergency department boarding. And so this happens, for example, when an adult or child goes into the emergency department with a mental health need and there's no place for them to go. We looked at what was happening in Oregon when those kids show up, and how many of them were spending a long time in the ED, which we defined as 3 days or more. I don't know what the right number on this would be, but you might want it to be 1 in 1,000 or 1 in 100. We found that was 1 in 8. So this is happening almost every day somewhere in Oregon, where some child is showing up at the emergency department with their parents. They're looking for help, and then they're staying there for 3, 4, 5, 6, 7, 8 days. I'm not sure if and so I think my point here is I'm not sure if this is the solution to that. I think it does a lot here, but there's still some issues with the behavioral health system. Quality, I like the emphasis on simplicity and reducing administrative burden. I think, general question I have about quality is, one, we've done a lot of this over the last 15 years, a lot of value-based payments. Are they attached to real consequences? Or are we just reporting, focusing on the reporting and the coding piece? I didn't see a lot of information about how many measures are there, 2, 15, 50. I often wonder, what would it look like if instead of, I think providers are sometimes tracking 25 or 30 or 40 measures. I've sat in meetings where they kind of look at these and they go, well, we can't hit that one, so we'll ignore that one, but this one worth within 5%. So let's go out and call people and make sure they get their vaccinations. What would happen if we sort of picked one measure that was very ambitious and set big incentives behind that measure and really focused on what that does to change the delivery system? There might be spillovers across other clinical areas if we really looked at ways of trying to change care. Again, I may be blue skying here, but maybe that's what I'm here to do partly. Okay, long-term care, I think I just heard some comment there. I won't say more. I think this is a really tricky one, and so leaving that off the table for now sounds great to me. Okay, so what about some things that we could do that have broad consensus? And it listed 3 here: global budgets for hospitals, reference pricing or a standardized fee schedule. Those are slightly different, and then consolidated pharmaceutical purchasing. Hospital global budgets, this has been done in one state. I think this maybe sets the incentives correctly. It requires, some real significant coordination with the federal government, but that's not necessarily off the table. But it seems, I think this is one that many people could get behind in terms of what the evidence suggests there and in terms of aligning the incentives. Reference pricing or standardized hospital fee schedules. I think this is an attempt to get to remove some of the variation we see on the commercial side. The state publishes lots of data on what hospitals and providers are actually getting paid for certain services, and the variation there is quite striking and doesn't really have a lot of. It's hard to rationalize a lot of it. This would do some fix to that. There's good evidence on these types of things. Consolidated pharmaceutical purchasing. This is meant to kind of put the market power back in the state's hands. So we have one purchaser or maybe a limited set of purchasers instead of many. I think there's a lot of logic behind this. Makes sense. This won't solve everything. Last time I checked, pharmaceutical spending was maybe 15% of total healthcare spending. So it's some place to start, but it's not the only thing that we should be doing. I think all of those have a really good potential for cost containment, which I think is going to be really important for any universal healthcare coverage plan. I think that's one concern about the Affordable Care Act is, it focused on coverage, and the idea was like somehow we'll figure out the cost containment piece later, but it hasn't really happened. I think, there's a question of whether we kind of go for universal coverage now, or at least the plan sort of, does that, or whether there's staged or phased implementation. There's a concept in political science called policy feedback, which suggests that you look at these and sort of make sense of whether short-term reforms are in simpatico with long-term goals or whether they're at odds. And so sometimes you might make phased implementation changes or staged changes that actually make it harder to get to where you're going. I think you could make the case that some of the things that the Affordable Care Act has done has sort of entrenched us in the system that we're now trying to get out of. Even though people got coverage, it sort of makes it harder to get there. Other short-term policy strategies might put us on the path of longer-term system change. I think, there's a good case for moving forward here, administrative savings. And when I mean moving forward, I think moving towards universal health coverage, administrative savings requires some consolidation. And so if you're doing little bits here and there, you probably won't get those full savings. Bargaining power scales with coverage. And so again, if you're kind of moving in a staged manner, you might not kind of have all of the market power that you want. And I think, as I mentioned before, path dependency cuts both ways. And so this may be a reason to kind of push for a decisive move towards single payer universal health coverage that covers everybody. If you don't do that, if you sort of stick with incremental reforms, you might entrench the status quo more than building towards it. And this might be kind of what's happened with the ACA or what happened with Massachusetts. I think there's also a case for phased implementation. And so, there's possible sequences for market entry. So maybe starting with one group, building on that, sort of kind of, all of these are complicated, complex, require negotiations with federal state partners. And so there may be some feasibility there may be some attractiveness in terms of how you think about this and phase this out, sort of do some of this work. There could still be some administrative savings that comes from some phasing, and so billing complexity might start to happen right away. So it's not just sort of a binary flip where we've got everything taken care of and administrative complexity is reduced to a minimum. There might be incremental changes where you do get some real savings there. And then maybe some lessons from Vermont. So Vermont attempted a full system switch without proven capacity, and things kind of fell apart there. And so I think it's a lesson for caution, perhaps. So final slide here. I think the question at hand when I look at this, I think that the constraints are real. I worry about fiscal capacity, state competence, federal limits, and engaging the federal government. What the political economy is, who you have to sway over to make this work. I also believe, as I mentioned incorrectly at the beginning of the presentation, but awkwardly in the middle of the presentation, the opportunity is really real here. That I've really come to see that what we have is just not working, and I hear it again and again and again. I mean, people are just shocked when they look at their premium increases, or when they have health insurance, what they're ending up paying out of pocket, or what it's like to see that you really need care, that you have a child who needs a certain specialist, and that the next appointment you can't get isn't for another 10 months. So I think people are really struggling with the current system, and the system does feel like we're really struggling. So there's a real opportunity here. And I think my kind of framing here is, whatever proposal you come up with, whether it's full or phased, is it ambitious enough to matter, and is it credible enough to survive? And I think there's probably a case for each of those to be that. But those are the questions that I would put to you, and I think that's what you all have to face when you're thinking about where to go from here. So that's my final slide, and I'll close this and take any questions.
Thank you so much, John. That was fantastic. I'll open it up if any board members have questions. I can get started. I really am interested in this idea that you brought up there toward the end, that there are certain policies with this kind of work that get us closer to the long-term goal and sort of build us there. And then there are other sort of short-term policy fixes that we think are in service of that goal, but end up cementing us into a broken system. Can you say more about that? How do you tell the difference? How do we know if we're on the right track?
Well, I tried to put up some that I think are kind of would be moving us in the right direction. So, hospital global budgets, I think that requires, some of the coordination that would be with the federal government that probably would be required with moving towards a single payer universal health coverage one. I don't think that necessarily sets you back if you get that. I think ones that maybe make me a little bit more, I'm going to have to do this on the fly, but maybe would make me feel like you're not getting there as much are sort of more reliance on value-based payments. And I think we kind of had a lot of enthusiasm. I was a big proponent of this maybe 15 years ago, that value-based payments would be a way of using the market for good, that we set the incentives right, and and we kind of hope that once we do that we set everything right and we get better quality and lower cost. But really, I don't think that's done what we wanted to do, and greater reliance on that, to me, seems like you're sort of falling back on what I would describe as kind of a hybrid market system right now. I'm not opposed to markets. I guess I have to say that as an economist, but I think that whatever we have, whatever you want to call this, our hybrid system here, just is not working for consumers. And so what you've got value-based payments that don't really seem to be doing much in terms of quality, don't really seem to be doing much in terms of cost control, still allow providers to kind of use market power to raise prices when is needed, haven't dampened enthusiasm among outside investors, venture capital, for sort of coming in. We've seen from some of that the data on those when they come in that mostly what that's about is increasing volume, increasing the upcoding the billing, not really changing care for patients or reducing costs.
Yeah, so just to clarify, in that context, when you refer to value-based payments, you're talking about sort of pay for performance. If you perform on these metrics, you get these bonus payments or sort of incentives to do that. On the other hand, sort of like the goal was, improving the quality. And so, and we talked about having meaningful, consequences for not performing on quality measures. It's hard to sort those two. I think that we get stuck a little bit there. Like, how do you ensure that the quality that's happening, that reporting quality metrics has some teeth to it, has some meaning to it, and yet recognizing that like a pay for performance system has really failed,
Yeah, and I think so yes, on the yes, I think when I think VBP, I'm thinking pay for performance, but also there are value-based payment types of things out there like accountable care organizations and other types of things, total cost of care parts of the contracts that include more than just the quality piece and are designed to the design is to come up with something where you get a little bit more money if you can reduce the total cost of care. And I just don't think that we've done a lot of experimenting. I'm still open to that, but it's not, it doesn't, the results are not really as strong as maybe we thought they were going to be 15 years ago. And so, and they do kind of maintain the same system in a lot of ways that we have. And so if I had to kind of peg a direction I don't think would be beneficial would be more reliance on ACO type payments or total cost of care type payments or P for P types of payments.
Mike, go ahead.
Hi, John. I had kind of three areas of questions for you. The first was just, you haven't mentioned any kind of global best practices. I'm curious about your research. To what extent has it included, best practices globally? The second question area is, we didn't have a lot of for-profit stuff when I first started working in Oregon. We have all kinds of for-profit type things. Regard to that, it appears to me, John, that most of the cost increases, at least recently in Oregon, are not based on utilization. They're just based on the providers are being paid more per unit. And my third really has to do with, you haven't really mentioned healthcare as culture. I mean, I'm also trained as an economist, and I guess I've learned that healthcare really doesn't work in any kind of traditional economic way that we've got, because we don't have a monopsony here that other global places do to actually create some dialogue and exchange between the consumers. So I was hoping you could comment on all three. Thank you, John.
Yeah, I think so. To the first one, global best practices. I think this is a really important question, and I tried to put some things out there that I think are in terms of cost containment, where there's at least decent evidence. We're still learning here. I wish I had more to say here, but I think part of the problem is that we don't know, and so I'll give you two examples. We knew about the cost growth benchmark target. You guys can fix the order of the words on how that goes there. We knew about that going back a ways, and this was staged very nicely. So, the legislation passed, there was a work group that put together the plans, then it was implemented. Stage one was, now you can, here we go, providers, you can see what your data looks like, but we're going to keep that private. Stage two, now we're going to make it public. Stage three, there's going to be some penalties here if you don't meet those. So it's not like this happened over a year or 2 years or 3 years or 4 years. This happened over time. I don't know. I've asked. This is not a scientific study. I have not been able to find one example of a hospital system taking this seriously and really changing their delivery system in a way that was designed to meet that cost growth target. So that's a state-based target that was supposed to have some firm pieces there, and I don't know if anybody changed care. So I just leave that there. I don't think we're doing enough there, and I could be wrong. And you know, if this is public, maybe I'll get some nasty emails there. But it's sort of, you know, I think this is like, why aren't we doing more? Why aren't we sort of pushing to really try to meet that? That was something that was voted in by the legislature, and that's something that the providers should be trying to meet. I don't know if there were any real substantial efforts to try to meet that. So I think that's one response. I think the second is around the CCOs. And I heard some comments there. You know, there have been a lot of experimentation. There has been a lot of success. The CCOs started more than 12 years ago. And they have a lot. I really like the design of them. I think there's a lot of positive things to be said there. But if you went to take that and port that to another state, so I feel bad about this because I consider myself very interested in Medicaid. That's my main area of interest. I feel, you know, a devoted Oregonian. If you ask me to kind of pick the top 3 strategies that CCOs are doing to manage Medicaid population health in a sustainable way, I don't know what they would be. I'm not sure what the great lesson is of the CCOs are. What's their great innovation, or what are they really doing here that looks like different than managed care organizations? I talked to somebody the other day from a managed care organization and asked them what their most successful cost containment strategy was, and the answer was improving payment integrity. So this is around sort of focus, you know, making sure that they're not overpaying things. That does not sound to me like delivery system reform that is really improving population health, that's really focused on controlling the cost of care. So this is a little bit of a negative answer and maybe a little bit of a rant to a really great question, but I also experienced some frustration here in not knowing what the right answer is to reducing, to really sort of setting a system aside. And I think it's part of the reason that I have become more interested or more that my feelings about single payer universal health care coverage have changed, because I don't see in this hybrid system things where, oh, the commercial market did this and that's what we all have to drive to. Medicare did this and we're going to go there. The CCOs did this, they figured it out. We have lots of people trying different things. I really laud the experimentation that's happening with the CCOs. I love the CCOs and a lot of what they're doing. But it's been 12 years, and I don't know if we have like a great model or framework to do. So that's a long kind of negative answer to a really great question that I wish I had a better answer for. On the for-profit piece, yeah, I think, you know, what I would say is market power matters a lot. I think that providers across the country are doing a lot to create vertical and horizontal integration, and Oregon is part of that. And that studies are very, very consistent. I think this is, you know, one thing you can say among policy and economic studies. They often find conflicting results not in this area, and that when you see mergers and systems come together, that they most often raise prices, and that we rarely see efficiency gains. I'm somewhat, you know, I'm suspicious of the for-profit piece, which is how you asked that question. I'm still retain some, you know, agnosticism around that, because I think some of the non-for-profit groups in Oregon look a lot like for-profit groups. And we don't always necessarily, just in the data, if I kind of just have to rely on the data, we don't always see worse behavior or cost, you know, or sort of worse quality or kind of worse things among the for-profit groups. So you know, I'm concerned about some of the for-profit incentives, and I'm concerned about the growing role of venture capital nationally, and you know, and potentially within Oregon. And those data don't look so great, the venture capital pieces, but just on the for-profit, not-for-profit side, I think I'm still, you know, don't love it in terms of the incentives, but don't always see things kind of pop out in the data. On your culture question, you know, I think this is just sort of, you know, I guess there's a famous article by Nobel Prize winning economist Kenneth Arrow that was maybe the first one published in Health Economics, where, you know, he said, you know, this is a different market, and really what we can rely on is physicians and their sort of professionalism in terms of what they're really in this for is for patients. And that might be my response to your piece on the culture. I guess what I would say is, yeah, I feel like we have erred perhaps in the last 15 or 20 years by thinking that this is just a market, and we haven't really thought so much about a lot of physicians are not in this just to make money, but in this because they want to take care of patients. And that would extend that beyond physicians to people who work in the healthcare system generally. It's not true for 100% of them, but I think for the majority of them. And and I'm not sure that the current system really reflects kind of where their values, goals, and culture is.
Thank you.
Thank you, John. I really second most everything that you have said. And I do think back to my experience too in for-profit versus nonprofit. Even quite a few years ago, I kind of came to the conclusion, well, at least the for-profit systems pay taxes. And that helps out the general good, where the nonprofits that are acting like for-profits, have a tremendous amount of tax breaks everywhere, and we don't benefit from them. So anyway, I think it's sometimes hard to see one for the other. I really also liked your discussion on the bargaining power scaling issues. But I guess I've been looking, and you're mentioning that, and what we know, I think, is that pharmaceutical is often blamed as the really bad guy in the whole game here. But they really, when you look at it, it's 15% or so of the total spend on medical care. But one of the things then also talking about moving in the direction so that we get to what we want, it's one of these small step things again, on whether something like a single PBM for the state or something like that, whether that really helps us get to where we want to go, or whether it actually backfires on us and just put something else in place that makes it more difficult. So I think that the whole issue about what small steps, or even this could be considered big steps from the people who are in the pharmacy industry, what might help us get towards something that really does benefit kind of the single payer. So just thoughts on that, because I know that the legislature, Representative Nose has really commented on, like Ohio, that has gone to a single PBM, and whether we ought to do that or not. And just kind of the struggle with some of these things that you can't respond on every specific idea, but are there some general principles or things that we should be looking at as we decide, would this be a good, quote, stepping stone or not?
Yeah, I think I don't know if I have any particular insights as to kind of the political piece, whether a single PBM entrenches things or not. To me, it seems that it would be in simpatico with moving towards a single payer. Sort of separating out that issue, it strikes me as a good policy move generally. I'm not sure. I think a lot of other states have moved towards this. It's not clear to me why each CCO would kind of want to have its own PBM, and I think other states have looked at kind of trying to bring together their purchasing power. I think this is especially, there's a lot of interest around that when some of the new hepatitis C drugs came out. So I see lots of good reasons to do it in terms of what it could do for spending, and I think just sort of general confusion around the rationale of having multiple different PBMs across the state.
Thank you. I just have one last thought about when you were talking about the motivation of healthcare professionals, physicians, nurses, all of them, with many of them really dismayed that what they're having to do now in their jobs is not what they felt, that why they went into it in the first place. And so the moral hazard issue, all of that. And I totally agree that somehow we need to interact with those providers around trying to build trust again, and trying to have their input into how this would work for them and feel for them. And I just think it's something that we haven't been able to do yet. We don't have the funding, all of that, and we're doing some focus groups that hopefully will get at some feedback. But I just really feel like it's a huge issue, and if we if that we need to engage somehow in the whole provider system, from hospitals, from in clinicians, et cetera. And so I think that culture issue is really an important one. Thank you.
Thank you so much, John. We're so grateful for you spending your time and offering your expertise to this board, and we really appreciate that. We're grateful, and I'm sure there'll be a few follow-up questions we may send your way by email.
Great. Well, I appreciate the opportunity to present and really appreciate the work that all of you are doing.
Thank you. Okay, let's take a 10-minute break and plan to come back at 10:50. We're going to get started again here in just a moment. We are back on the recording, and as everyone is gathered, we'll get started again. The next presenter will be Kate Shadell, apologies for the pronunciation, from Milliman. She's going to be giving us an overview of the operations report.
No worries. Would you like me to share my screen?
Would that work for you, Kate?
Yep, totally fine. Okay, I'm working on it now. Okay, everyone can see that all right?
Perfect.
Perfect. All right. Hey, everyone. Thank you so much for having us. We have not been back at the board since September of last year, right when we were just getting started. So happy to be here today and present our organizational structure proposal, staffing, and administrative costs. I am joined by my colleague, Stephanie Ross. And so just to start, I know that it has been a while since we've been in front of you. My name is Kate Shadell. No worries on mispronouncing my name, Helen. It happens all the time. I have a background in public health, and so enjoyed the conversation that happened earlier today. Joined by Stephanie Ross with her Master in Health Administration. We also had two other colleagues work on this with us, John and Caitlin, who are not on today, but were a really important part of the work here. And then we'll also say a shout out to Fritz and Ken, our other half of the Milliman team that are working on the overall cost of the UHP. I know Fritz is on as well, so thanks, Fritz. All right, just as a reminder of where we have been and where we have ended, is we started this engagement in 2025 with you all, really engaged in strategic conversations with Mimi and her team, with the operations committee, with Helen, with various members of the board, just around the overall goals, success metrics for operating the UHP that we've incorporated into the work that we've done. That led us to design a proposed organizational structure that really highlights key leadership positions, departments, and reporting structures. Once we sort of had a sign off there in this iterative process that we tend to follow, that helped us shape our staffing roles, how many staff we have estimated, the technology systems involved, and any other operational demands. And then we used all of that information to come up with an administrative cost estimate for the UHP. We had done that previously for 2026, and we've trended that forward into 2032. And those numbers are what you will see here today and in the final report that we deliver to you all. All right, so we'll start with the organization structure, and then once we get into costing, I will pass it to my colleague, Stephanie. Okay, so when you look at this screen, I wanted to start here with a high-level view of a traditional health plan. And so this traditional structure is really grounding our discussion. It's where we started before we built an organizational structure for the Oregon UHP. This really illustrates the major functional areas of how we typically think about responsibilities and how they're distributed across a plan. So I will walk you through this to ground you in where we started. And then on the next slide, you'll see how we've adjusted this for the UHP in particular. So you'll see these 5 large functional areas, starting with operations here on the left. This is really the core engine of the health plan. It handles some of that provider network management, your member services, your claims administration, as well as your sales and marketing in a typical plan. That second one we have here is administration, and really run by a chief administrative officer. It ensures the plan's meeting sort of all those regulatory expectations, managing risks, supporting internal workforce needs with things like a general counsel, human resources, compliance, and facilities as well. The third category we have here is finance, run by a chief financial officer. They're overseeing actuarial services, rate setting, financial planning, accounting, and treasury functions. And those actuaries that we get to work with every day, they play a critical role in setting the rates, trending, forecasting, and really thinking about plan resources. That fourth category here we have is the information technology. I know there was some discussion around that earlier, so we've really sort of blown this up into see what traditionally goes into the IT organizational function category for a plan. It really supports data-driven operations, app development, essential IT infrastructure for anything like performance monitoring to utilization insights, compliance as well. And it's really that technology backbone that supports claims, enrollment, member services, and core systems. And then lastly, we have medical management, often overseen by a chief medical officer. They're focusing on that clinical quality, utilization management, and care management, and then behavioral health and pharmacy operations as well. And so, again, we use this as a baseline to compare against what an alternative model or a modernized model might be for you all, and then adapted it here on our next slide. Okay, so just a key to some of the colors on here, if you see that sort of light mint green, those are similar roles as were in that traditional staffing model that I just went over. Anything in purple has been really added or adapted for the Oregon UHP. And then you'll see in that dark green color, we have some roles that are traditionally outsourced by plans, but wanted to add those in here as well. So I will start with the first bucket, operations, highlighting some of those key changes. First, oh, sorry, I will back it up. First of all, I'll say that you want this to be run by a public corporation, a board of directors, and then maybe have a president, CEO, executive director overseeing all of these 5 functions. One of the major changes in the operations bucket is really thinking about marketing sales does not take place in the same way under the UHP that traditionally happens in your healthcare model that exists today. And so we've changed some of the names and shifted that based on conversations we've had, based on listening to past conversations that the board has pursued, and thinking about shifting this on how the plan changes will be communicated, how they are managing public affairs, how y'all are thinking about community partnerships as you build this, including coordination with some of that public health, and then thinking about community engagement, incorporating feedback from the voice of the people, and adapting it as needed. So we've changed that typical marketing sales into a marketing / communications here. I will skip over administration for the moment and shift over to finance, where we've added sort of an audit and financial compliance piece. This is really helping monitor expenditures, which will be important into the overall plan here, ensuring transparency and integrity, especially being such a monumental shift here and a new, hopefully the first universal health plan in the United States. And then next I'll shift over to medical management. The positions that we have added here are focused on health informatics and analytics, which I think will be very important as you're thinking about both the medical care here and then that second position that's focused on population health. Population health is in 2 different places here. It's both under medical management. We know there are population health work. It's being done in the hospital system. It's being done with social determinants of health screening. It's being incorporated into what has been traditionally just medical care. So we've added those. And then as we shift back into administration, this is the largest change. If you see that purple column, Mary, to your point that you made earlier, and me having a public health background, and I know Mimi does as well, just really thought, okay, what about all of the other things, right? So we put in a chief strategy officer here and incorporated really important items such as policy and how you're thinking about the coordination for federal waivers, how you're thinking about legislation, working through these regional proposals and changes. We also think it's important to keep track of how this is working. So evaluation and research, cost benefit analyses, health impact studies, how this is implemented is equally as important. We also know while there is a piece of quality to medical management, we also put it in here, overall quality metrics, accreditation, public reporting, we think it sits here as well. And then sort of these last three buckets are all around public health. There's going to have to be public health coordination that aligns with OHA, aligns with local health departments, that's thinking about priorities as far as prevention, screening, public health services. How are you thinking about health equity and inclusion? That access is not the same as getting an appointment. So thinking about demographics and language and cultural competency and other elements there as far as care. And then thinking about, as you move this forward, what does the health system integration look like? That's going to be a key piece of implementation. And then innovation. So piloting new care models, thinking about innovative care, thinking about telehealth expansion, potentially here also alignment with that rural health transformation project that's just now starting and will continue to help scale up rural health capabilities as well. So that is the biggest shift, is adding in sort of that chief strategy officer in administration. I also added one other additional piece here under the chief administrative officer related to privacy, thinking about HIPAA and state data compliance, especially as you think of consolidating into a single EHR. And so this, again, is a potential organizational structure. It's based on the conversations we've had with your staff, with your committee members to date. The future of this structure could vary based on your final benefit design, your operational approach, how you implement it, and when, any regulatory requirements and organizational priorities as well. And then lastly, the one thing that is also included here is that blue box there at the bottom is I also see that chief strategy officer overseeing those regional health teams. I called them regional health integration teams. I know we've talked about regional entities and we're looking for a different word. And so thought about what that might look like as well as we move forward. And so I've added that in the next slide. So I will keep moving, and I think we'll do questions at the end. So lastly, we have been thinking about how the regional health teams may look. In talking with Mimi and talking with operations committee, we have some really good feedback and know that these 6 blue boxes are priorities. They've been put forward in the straw proposal that Lee has developed, thinking about provider education, workforce development, member outreach, community engagement, local innovation, and then also the health resource planning and prioritization. And so what I have proposed here, again, is just a varying degree of staffing needs and level of autonomy, knowing that as I work here from left to right, all of these could vary. They could be a mix and match model, but just wanted to put some pen to paper so you could react to it. So I've started with maybe your most basic model. I've called it a regional coordination model, where it is a smaller team of staff of just maybe 2 to 4. They have a coordinator that's leading it, and maybe that community advisory council, which is there as a volunteer support as you coordinate with regional entities or health teams around the state, thinking about maybe we're just looking at provider education and we're thinking about workforce. And that regional coordination model allows you to keep a good pulse on what the workforce looks like now, maybe what the needs are, maybe what some of those public health struggles are. And it's less resource intensive to have a small staff, but you're still looped back into a larger structure. The cons of that is just, you know, you have a small staff that does not maybe allow you to act as quickly on some of those needs as you build them. As we shift into this next model, I've called it the regional partnership model. Similar structure, you've got a regional lead there and then a community partnership board. As we think about is a volunteer or stipend, either one of these could work for the model. But this has a slightly larger number of staff, 5 to 7. You still have someone focused on the provider education and the workforce development piece, but I've added some of those blue boxes in at the top here. So member and community engagement into one, maybe a data analyst, maybe a health resource planner. This allows a slightly larger team to maybe pilot some local innovation or workforce improvements, think about how we better integrate health and the social services that live there, you know, what resources exist, how can we tie them together. Even the discussion earlier of like, how are we thinking about those that are experiencing homelessness and other social factors here. And then maybe with some someone dedicated specifically toward data, some better data sharing and quality improvement here. So again, pros to this this model, their shared accountability in each region, really taking some of the ownership on as a regional team. But as a con, this could result in some variation in quality and services provided and would require more oversight from that sort of larger organizational structure. And then lastly, I have this regional operations model, which has the most autonomy, led by sort of a regional executive director and a community advisory council again, but have added slightly more staff here that you've got some administrative staff, you've got some operational staff that are helping support some of these initiatives. Perhaps with more autonomy, they're thinking more about how they can actually do some local contracting and really influence the workforce here. You're really looking closely at the health resource planning and prioritization and start to prioritize some of those things. And you're looking at your data and working really in quality improvement to make some changes that could be lasting there. This would require a lot of administrative oversight and alignment with the UHP as a whole, but it allows for some high local ownership and responsiveness. I've made a note here, staffing sizes can vary. The discussion that we've had both with Mimi and team and the operations committee is this is not a one size fits all. It is not a you must pick one. You can pull different elements that you like from each one. You could also start small and grow larger. There is really a lot of opportunity in thinking about how you're coordinated to regional areas around the state, and just am excited to think about them and brainstorm them with you all. So with that, I will pass it over to Stephanie, who will run through the overall staffing numbers and the administrative costs, and look forward to questions from you all later. Thank you.
Thank you, Kate. So to kick this off and set a little bit of context, the model and everything Kate just described and walked through was the foundation that we then built our actual numbers and projections off of for both admin cost and staffing estimates. So go ahead and go to the next if you don't mind. I want to lay a little bit of the groundwork before we show the numbers, kind of bury the lead for a second, just so you can understand how we developed our projections. And it started with the work out of the PD&E committee to understand enrollment and kind of projections for Oregon as we think about this 2032 go live. And so in our model and the way that our benchmarks work, we operate this by line of business because of the business mix variation as well as complexity variation across different lines of business. That has implications on how you staff administratively and kind of what those associated costs are. And so enrollment, we use the same enrollment that Fritz and team used in their PD&E work to make sure that we were consistent and carrying that forward. As you can see here, roughly 4.4 million in 2032. So that is one underlying piece that goes into our benchmarks. And then for context on our benchmarks and how they're developed, they are based on data from payers across the country, a variety of them across multiple lines of business to make sure that it is industry representative and all inclusive. These kind of develop our baseline benchmarks, and those are updated on an annual basis. And then we incorporate specific different things for clients to customize those benchmarks to models and operations for that specific client. And so those key adjustments that I'm talking about, and we'll go through in a second under our assumptions, are related to the business mix, as I just described. The plan size, is it kind of total enrollment overall, small, large, how does that grow? The geographic cost index, so right, Portland and Oregon versus New York, there's variation and what those costs are, not only from a plan standpoint, but even a staffing standpoint and salary component. And then obviously the administrative and operating model and how those different roles and structures shape out. So this is slightly different than what the ops committee would have seen in December, in that we heard your feedback on including dental, vision, and behavioral health. And so those have been incorporated in these numbers that you're about to see now. Pharmacy is still excluded. I do want to call out that that is oversight of the pharmacy management services, but not actual cost or staffing to administer those benefits. On the efficiency side, so obviously with this model and what Kate had just talked through, there's a variety of different efficiencies that are anticipated to operate a universal health plan in comparison to a traditional health plan model. And so she had briefly mentioned provider contracting, premium billing and reconciliation won't really exist in this scenario. So a lot of that is taken out. Coordination of benefits, there will still be a little bit of that if we think about like TRICARE and potentially private payer business that would still exist in the market. But for the most part, you're going to eliminate that like dual, where today a payer may be coordinating benefits for someone that is both Medicare and Medicaid eligible, and it has to kind of prioritize who pays first, how do we process all of that. A lot of that will not exist in this model. Sales and marketing, I know Kate covered, but you won't have the same kind of business development activities that are typically in a plan. And then last but not least, the kind of corporate services overall based on size and simplification. You are removing a decent amount of complexity and oversight and optimizing kind of those underlying operations and teams that are doing the work. Lastly, just closing out that this aligns with the PD&E work. We incorporated the additional staffing needs that Kate talked through. As you saw, those are kind of smaller numbers. So in the grand scheme of the total projections, there's not too much of an impact, but they are included. And then these numbers that we're about to talk through represent steady state operations. This does not represent startup cost. So this would be once you are operational, this is what you're looking at from like an annual basis. Staffing. So the way we broke this out, same 5 buckets that you just saw: operations, admin, finance, IS, and medical management. We presented it in 3 scenarios. So highly efficient scenario where you're running the most lean, and then a less efficient scenario where you're running a little bit more heavy on staff. But then that middle column is really where to focus attention, because that is best estimated scenario based on what we have learned from the ops committee and feedback from Mimi and team on how you were thinking about this and designing this and the operational model presented. So roughly that 15,000, 15,800 individual mark as we think about staffing and FTEs. These are full-time equivalents across these different operational areas. And then translating from the staffing side into the admin cost. So really quick, I guess a level set as we think about administrative cost. Traditional health plans run around what we typically say is 15%. I think back in September, we had shown this to you where medical expense usually accounts for around 85% of a plan's expense. And then admin expense accounts for about 15%. That does include profit share usually. And so as you can see here, I just want to ground that, because when you're looking at the UHP, we're looking at a range of roughly 4 to 8% admin cost, which is substantially more efficient than what you would see in a traditional plan and operation. And then again, in that middle column, looking at what the best estimated scenario is of roughly 5.1 billion in operational expense, which accounts for nearly 6% total from an admin ratio standpoint. This also is all inclusive. So this is that total enrollment of the 4.4 million that we saw on a slide previously. I think one thing to note as we transition into the next slide, we did want to remove the Medicare population. So Kate, if you don't mind. Thank you. Based on conversations that have kind of happened, I would say over the last 2 months across our engagement, the topic of the Medicare population and including or excluding has come up. And so we did want to run the model analysis for you and present kind of what that means administratively for the UHP. And when you look at this, first most immediate thing you probably notice is that you're looking at roughly 2.8 billion versus that 5.1. So I think two important things to call out on why you're seeing such a decrease. One is truly just the volume of Medicare members and enrollment. So on that previous slide, your Medicare population accounts for roughly 25% of your enrollment. And so by just carving that population out, you're decreasing the volume of enrollment, and then therefore it impacts overall PD&E as well as admin. And then the other part of that is the complexity of the Medicare population. So all of us know that kind of that population tends to be a higher illness burden population, more chronic conditions, comorbid conditions, kind of more high utilizing of services. And so when you remove the complexity of that population as well, you're gaining more efficiency by kind of having more of a general traditional adult population in your plan. And so those are the two factors that are driving that variation between including Medicare and excluding Medicare.
That is it for us.
Thank you so much. Go ahead, Judy.
First, thank you for this presentation. I appreciate how you've incorporated feedback from operations committee. I see their voices throughout, so thank you very much for that. My question is about when we were just looking at the estimated cost on the scale of efficiency, how does the choice of the regional team model play into that cost scale estimate?
In terms of which model of the three Kate presented in impacting that total admin cost?
We're just looking at two different scales. We're looking at a scale of efficiency versus a scale of like intensive administrative team structure. I'm just wondering how they impact each other. Like, how do we interpret that? If we wanted a really complex regional team model, how does that impact administrative costs?
So I'm going to speak like qualitatively because I don't have the numbers in front of me of like exactly how that changes if we change the regional model. But in terms of the overall impact, given the size of the regional models and regional membership, when we're talking about roughly 15,000 employees in total and your regional teams, if there's 7 of them and each of them are 10 people roughly, that's only 70 people. And so it will not be a substantial impact depending on which regional model you choose. I think where you could start to see potential inefficiencies or more complexity is just in that oversight bucket. So if you do have that more intense regional model, you're going to have to be more intentional about your kind of enterprise level or state level oversight of that. But from a true impact to your cost as well as staffing numbers, it's not going to be substantial.
Go ahead, John.
Thank you for your presentations. I have a brief, not necessarily a question, but more of a reference point and comparison. I've been working with Taiwan's National Health Insurance that they just celebrated the 40th anniversary last year. And my comparison is regarding the total FTE staffing. So Taiwan's National Health Insurance covered 23.5 million. That's about 5.5 times of Oregon's population. And its daily operations are fully decentralized in 6 regional offices, from payment, enrollment, monitoring, auditing, all decentralized. And that's how they hire those staffing. So to operate this national system with 23.5 million, its full-time equivalent is merely about 3,000. So
Wow.
just
Yeah.
for reference,
Per region or?
no, total, national. That cover 23.5 million people, 6 fully operational regional office.
Yeah, Stephanie, can you say more about how you came up with that number and how it might compare to what we know about how many folks in Oregon are currently employed in the health insurance industry, including, OHA and Medicaid? I don't know if you have those numbers, but where did that number come from? It does seem pretty high.
Yep, so that number is built based on our benchmarks and all of the decisions around the operating model and what we know across the industry and across the United States. And so it was a build up of that to get to roughly that 15,000 number. I think one important thing, and I know we don't have it in front of us now, but one important thing to think about with the staffing is it's obviously a pretty wide range. I think our range was roughly 11 to 21, maybe. And that range is due to the variability of operational decisions. And so I think a good example, and I know we talked about this in Ops Committee, was like, if Oregon decides to lean heavily into technology and AI and automation and different systems, it's substantially probably going to reduce your FTE need on your operations department and section there. And so those types of operational decisions and things that are to be designed through implementation will impact that overall 15,000 number. The other part of that, and we don't have your current staffing numbers or current state information of like how many people are employed in health plans across Oregon, or how many people are employed by your 15 CCOs. I think if Mimi, you have that top of mind, please jump in and interrupt me. But one exercise that would be valuable is how does that compare? And are you gaining efficiencies by centralizing to roughly 15,000 as you think about transitioning some of those people and how they would need to stay employed?
I don't have the exact number. It's a pretty hard number to come up with, but I have estimates between 8 and 12,000 currently.
Okay.
Currently employed in Oregon in the health insurance industry. So going to 15,000 seems like it makes things more complex. And of course, all of those 8 to 12,000 a lot of those are very redundant positions. It's people doing the exact same function at multiple organizations in the same area. So that number still seems really high. All right, sure. I'm
Okay.
sorry, I wasn't paying attention.
Okay.
Mary
I
Lou,
think
next,
you
yeah,
were.
sorry.
Okay. My real question, I mean, I question all of it, honestly, about these numbers. They're just astronomical to me. But the medical management one is between highly efficient and not efficient, is between 13,000 and almost 25,000 employees. And so what, again, is this based on the current industry way of, in my mind, wasting a lot of time and money, saying no, having the providers beg for please saying yes, then saying no, just that whole kind of pre-authorization, just all of those pieces that I think what we're trying to do is get rid of that. We're really trying, or at least to minimize it greatly. So that's where I'm just kind of, and that interesting number that you said, Helen, that the total number in insurance or whatever, is
12.
yeah, and this is just the medical management piece.
Yeah.
So help me understand how that number came to be.
So you are exactly correct. It does include that traditional model of what we experience in the industry today. And so that, again, that is the baseline underlying model. And then we manipulated based on efficiencies. However, we do not know the medical management program designed today, right? And so the baseline is that projection. And then as you move into design and implementation, we would anticipate that changes. If we know that Oregon's considering no prior authorization activities, that's going to substantially reduce your need for medical management.
Go ahead.
I was wondering, and it sounds like no, but I don't want to assume, like kind of how Dr. Chinwei brought up kind of the Taiwanese model and staffing. Did you all look at countries that have universal health care and their kind of models for staffing and managing those? Because that's more similar to what we're trying to do than looking at our current industry model.
Yeah, I can answer that. Yes, the answer is yes. I've looked up operational structures and universal health plans around the world. I use some of that as the basis of like, you saw that slide of where we're starting, and then I said, okay, what are we missing? What are other countries using? What is not here? Which is really where some of those added functions were put back in, like someone overseeing policy, someone over thinking about health equity, someone thinking about quality. And so I have done pretty extensive research on all of those models and have an organizational structure and org chart for a lot of places that really informed how we built our Oregon proposed structure. Yes.
And then one is a comment on earlier slide in the kind of org chart for our new model. It would be really lovely if in the health equity and inclusion that you either add accessibility or accommodations or some reference to disabled folks just as being called out. And then I wanted to know on the pie chart with the like Medicaid numbers estimates for 2032, is the 26% based on like what we know now about HR1 and kind of, likeliness of the Medicaid unfortunately going down in the next few years? Or I guess like what were the
Yeah,
assumptions? It was
Milliman Incorporated.
incorporated all
HR1
that. Okay, all right,
Yeah.
got it. Okay, that's all my stuff.
Mike?
So first of all, thank you, Kate. I have a conflicting analysis of this. On the one hand, I know that as a former running Kaiser's health plan and having some roles in medical economics in Kaiser, that the fact that we have so many different insurers, right, really complicates things. And so part of my sense here is, I guess the first question too is, well, Amy and Chunwei have asked about, global comparisons. I appreciate how difficult this is because there's no other state we can really compare. But that stated, I'm going to ask you more of a hypothetical question because like here, there's no way in hell we're going to buy off on 15,000 employees, right? But did we give you various models? Like if we had a really simplified single payer that didn't do lots of medical management, that tried to bring the 4 million Oregonians and the providers together in a more collaborative model and single payer, and we had, one progressive pharmacy and the like. I want to get a sense from you, because you've really thought this through. How much would that be further reduced? I'm just trying to get a scale thing here. Would you come up and say it'd be 3 or 4 or 5,000 people, compared to this 15? Because otherwise, we need at least your input and guidance. And if we're going to do a really simple thing, that's different than if we come up with 7 CCOs or whatever stuff that we have now. So I just want, you kind of, if we would have maybe given you different instructions, 6 months ago, I think obviously you would have done much more global health and looked at other things, and you'd come up with very different numbers. So at least that's my sense, but and I don't want to be an unfair question. I want to know directionally, what suggestions do you have for us now?
So I don't have a number off the top of my head, and I will take that as a to-do and follow-up to get you a potential like efficiency range if we think about different changes. But to your point, absolutely. Like I do want to acknowledge our like model and projection is based in 2026, and then we trended forward to 2032 to account for, you know, the unknowns of what these next 6 years could bring us. And so depending on those decisions, and if you go more global and you sole source every operational function and you completely eliminate certain needs for traditional functions based on the like operational design decisions you make, I would absolutely expect that you would be able to be more efficient and have less FTE.
Thank you.
And like Stephanie presented earlier, the slide that has our modeling efficiencies, if there are more efficiencies, we put that into our model. That impacts your overall cost, that impacts your overall staffing. So yes, when you have more information and you have more detail, we can certainly rerun it in the model and look at new numbers. So that's very possible to do. Yes.
I guess sitting on the Finance and Revenue Committee with Cheryl, and we contemplate how to shift and restructure the funds that people are currently paying into a tax model, et cetera, to come with reasonable ways to fund this endeavor. These numbers just, you know, really are staggering here. And one of the things that one of our members who had formerly been a medical director at a large insurer in Oregon a while back said that when we talk about, I'll just use Providence, it isn't Providence, but Blue Cross, whatever, as a plan. I've got a Blue Cross card, I've got a Providence card. He said that behind the scenes, there were 2,000 differing plans. And so managing those 2,000 differing plans, and is that thing covered this way on this one or that way? And I think that's probably fairly true in, and even as a Kaiser beneficiary, I know now that Kaiser doesn't have kind of one Kaiser plan. There's a lot of Kaiser plans.
37.
What?
137.
137. Okay, so when you're basing it on the industry out there that has gotten so segmented and you know, I don't know, I won't use bad words, but but if that's the basis for this, I can see where you came up with these numbers. But we're really talking something different. So I think that's one of the issues going forward is
So-
how do we get
Yeah,
there?
so along those lines, I'm wondering, and forgive me if you've already done this, but you know, we've had several other states in this country propose single payer plans, notably New York, Massachusetts, Vermont.
Colorado.
You know, you don't have to answer this now, but I think I'd be interested in seeing like how these numbers line up with what they predicted, like how close are we to their estimates as well? It'd be really interesting for us to see that. If you have time and that's feasible.
Yeah.
We can absolutely take that as a to-do and debrief that with Mimi and see how she would want us to incorporate it in the report.
That'd be great. Thank you.
Yeah.
We have to move on, but I just want to say thank you so much for all your work on this. I think the structure and the way you've laid out the structure and the different functions is fantastic. A lot to think about with the role of the regional entities. And really, really good information for us to consider. So we're deeply appreciative of the work you've put into this and look forward to the report.
Just one
Our
quick thing.
pleasure.
I think this is a Mimi question. This was not on the web before the meeting.
Yeah.
And other people are wondering, is it gonna get up quickly or is it
Well, remember,
stuck with that other
We
thing
can let
that
our,
said?
we can let our consultants go
Yeah.
and hit.
Yeah.
Thank you so much to Kate and Stephanie. We really appreciate it.
Of course.
Thank you.
I'd like to-
Thanks. Have a great day.
Thank you.
Mhm.
And I'll just jump in and say, as Mimi said earlier, we have no control over when things get on the website. It's not in our control. So
It
Mimi, I
wasn't
don't know
that
if
they
you-
got it to us late. It was,
No.
Yeah.
Okay.
It's that, I mean, it's been sent to be posted. It just hasn't been posted yet.
okay.
And I don't recall that we got it in our materials ahead of time, the board, so that we could review it before that.
Okay. Sorry.
Did you see? No, but much of it was similar to the September operations committee report, the pie chart, those kind of things were in that September
Yeah.
report. Had to dig for it.
So looking at the time, I'm just gonna, I just want to respond quickly. I have a couple of slides that tag on to this discussion about administrative efficiency, and, you know, certainly we take all the concerns really seriously, and we're going to keep looking at those numbers. A question came up at our last meeting about administrative efficiencies and universal financing system or unified financing system and how that would work. And so I put together a little bit of information here. We can go through this very, very quickly, and then we'll move on to the committee report outs. Go ahead, next slide. So this is a slide I presented to the Finance and Revenue Committee about questions about whether or not this was a true single payer. And I qualified that answer. Certainly that's our intent, is to build a state-based single payer plan. But there are just some complications of doing that within when you're a single state within a federal system. And I guess my point in doing that was just to call that out, that it is not the same thing to build a single payer as one state in a federal system as it is if you were to take it on as a nationwide thing. There are just some serious complications, and there are real administrative efficiencies of a single payer plan. Nobody is denying that. But when you're trying to build a state-based single payer in a federal system, you lose some of those administrative efficiencies. Medicare is still going to exist. Medicaid is still going to exist. SAFE is still going to exist. Workers' comp, you know, like there's all kinds of other programs that are still going to exist that we need to work around and accommodate. In addition to the fact that we have enormous numbers of people, several 100,000 in Oregon, who cross state lines for work. They live in one state and work in another, and that creates another level of administrative complexity. So yes, while single payer has administrative efficiencies, there are also new complexities that we need to keep in mind. What we're doing, what we're always been committed to, is building a playbook for a universal health plan that covers everybody, paid by a unified financing strategy through all legally permissible funding we would put in there. We'd be paid through a state trust and operated by a public corporation. We have never wavered from that. That is absolutely our commitment. It's as close to single payer as an individual state can legally get. But yes, that's what we're doing. Go ahead.
You want to respond to Mike or?
Yeah, no.
No,
No, I'm just gonna go through these really
No,
quickly.
no,
I'm sorry.
My problem is I left it up.
Oh, you left it up.
Sorry.
Okay,
Thank you.
okay. So just quickly, there's a couple of systems that I know you're all aware of that are going to continue to exist. The VA system, the Indian Health Service, Medicare Part A, and ERISA. Next slide. And there is a federal legislation called SABUCA, or the State-Based Universal Healthcare Act, that has been proposed over multiple sessions. It's still, you know, an active bill in the Congress right now. And the idea is that this is a mega waiver. And if this was passed, then it would relieve a lot of the issues of single payer. But I want to dispel some myths about SABUCA that I think are really important for this board to know about as we start planning for what the next phase of our work is. So what SABUCA does is it allows a waiver of 9 different parts of the healthcare system for states. It allows those waivers, it doesn't require them. So that's the ACA, insurance exchanges, cost sharing reductions, employer mandates. You get a waiver for those. You get a waiver for the Medicare funding stream. That's important. We'll get to that later. You get a waiver for Medicaid, which would collapse into the state-based plan. CHIP is the Children's Health Insurance Program. And then the Federal Employees Health Benefits Program. So that's all people who live in Oregon employed by the federal government and the benefits they get as federal employees. TRICARE, which is a health insurance related to military service. And then ERISA, which we've talked about multiple times, which is the federal legislation that protects employers and how they offer benefits to their employees. Next slide. I just want to point out that Medicare Part A is a federal statutory entitlement. Individuals have a legal right to those benefits. They've paid into them. They have a legal right to access them. And that legal right cannot be waived by SABUCA. In theory, under the SABUCA waiver, you are redirecting the Medicare dollars into a state-based program. And so those dollars are put into the state trust that would administer the program. However, it doesn't eliminate the person's right to do that. So when they dealt with this in Vermont, the federal lawyers that were involved in the case determined that those individuals retained the right to access Medicare Part A and not participate in the state universal health plan. So even though the dollars were directed to the state plan, the individuals still have the right to opt out. So there will be a situation in Oregon where there will be folks eligible for Medicare who said, I don't want to be in the universal health plan. I want to just be in Medicare Part A. I'm entitled to it, and we'd have no legal way to stop them, right? Because SEBUCA doesn't cover, that's not part of the waivers of SEBUCA. It's just the funding, not the statutory. It's one of the reasons why Vermont's efforts failed, one of several, don't get me wrong, it's not the only run, but this issue with the legal complexity around Medicare is one of the reasons why that plan never went through. Next slide. In terms of the VA and TRICARE, they're different, they're structurally and legally distinct. TRICARE is the health insurance plan, VA is the delivery system. There's different rules for each of those. If you are an active duty service member, they remain on TRICARE under SEBUCA. SEBUCA cannot cover those members. So if we have active military service members in Oregon, they're not on the universal health plan. They're still under TRICARE. But if you are a retired service member, or if you're in TRICARE for Life, which is their Medicare supplement, those folks are in the same legally ambiguous space as Medicare. The funding in theory would come to the state plan, but those individuals have the right to access those services outside the state plan. So again, in a state-based system and in the context of the feds, we still are going to have a lot of administrative complexity here in terms of these programs. Next slide. Indian Health Service is specifically carved out of SEBUCA. They're not counted in the 95% coverage mandate that's in the legislation. Participation would be voluntary, and any IHS eligible residents who choose to enroll in the Universal Health Plan, their services would still be paid for by the federal government, not out of our funds. Their care is still paid for. So again, administrative complexity there. Go ahead. ERISA is the federal law, again, that restricts the ability of states to enact laws relating to the employer-sponsored coverage. If employers choose to self-fund, they can operate under a single federal regulatory framework instead of different state regimens. So this is an enormous legal advantage for businesses, right? They don't have to follow the state regulation. If they're an employer that operates in multiple states, they don't have to comply with various regulations from different states. And that ability to preempt state law is the key sort of protection that ERISA offers to employers. SEBUCA would waive that preemption provision, meaning that companies could be subjected to state laws. And then we don't have to do that. There's a lot of reasons not to do that. The employers rightfully would defend that legal right quite graciously. So we've talked about that before, that an ERISA challenge to the Universal Health Plan is almost inevitable, because that is a really important fundamental right of those businesses who operate in multiple states. Next slide. Okay, so the Universal Health Plan Governance Board is absolutely committed to delivering a report to the legislature that outlines how to cover everyone in Oregon under a unified financing strategy. That's the language we use. It's a technicality, but it's important to me. It's not technically a single payer. There will always be multiple payers in this state until we have a national single payer plan. It is unlikely that SEBUCA will pass. It doesn't have very much support, and it is very unlikely in this Congress that it's going to pass. But even if it does pass, we will always have federal programs operating parallel to the state plan that introduce a level of complexity that you wouldn't have under a national single payer plan. It's also important to realize that one state in a federal system can't recoup the savings from administrative efficiencies in the same way a federal single payer can. And so I think it's really important to consider that when we think of administrative efficiencies, that we will have additional costs, new administrative costs to a universal health plan that wouldn't exist if we were doing this on a national level. And then also, because these different markets have different rules and different waiver processes, it's really important, as John McConnell also talked about today, to think about a phase-in approach, because different markets have different legal requirements and different phase-in sort of advantages and disadvantages. So so that's kind of the idea there that we wanted to make sure that we emphasized. If anyone has comments or questions on that, we can spend another minute or two on that, and then we can move on to the committee updates.
I'll just add the operations committee has had discussion around how we address the wraparound of the federal care delivery systems, both the VA and the IHS, without interfering with their operations of those systems. We still need to discuss how to treat individuals who are covered by TRICARE and the Federal Employment Health Benefit. So they're involved.
I would just say quickly, when looking at the numbers like TRICARE, et cetera, they're really small compared to the big. So they are issues, they are operational issues, they will have administrative, whatever, but I keep in mind 4.2 or 4.4 million, whatever we're talking, versus 45,000 or whatever.
Right.
It's a relatively small, these various.
It is relatively small, but this was in response to, are we building single payer
Yeah.
or not? Not technically.
I agree.
It's a unified finance.
Webster,
Right, it's a unified financing strategy. That's as close as we can get. Go ahead, Mike.
Well, first of all, I think what you've done here in this summary, Helen, is actually very, very helpful to us, right? So it gives us a sense of focus. I would add that we all know this is very complex, and that actually there's another complexity, and that is we haven't yet dealt with a firm benefits plan, but as we do, I suspect we're not gonna possibly fully fund all of dental or oral or whatever. My point is that we haven't even discussed the fact that there will be, I believe, some insurers left for kind of supplemental health benefits. And at some point, we're not ready for that now, but I think we need to be ready for that. So there will be a role, kind of like Australia, where there are basics, but there are also other insurers that do.
Yeah, absolutely. And that's spelled out in our legislation, that supplemental plans can exist as long as they don't cover the benefits covered by the universal health plan. Yeah.
Right.
So yeah, that's in the legislation.
complexity, I guess, is what I.
Yeah.
Yeah, but
Administrative complexity.
Oh, yeah,
is what I.
Oh, yeah. That
And
adds
it's-
to the.
it doesn't go away.
Exactly.
But
Exactly.
there's two aspects. One is the benefit thing, but the second is, for instance, when I was at Kaiser, I was the national account executive for a few Boeing and a few other places. There are national accounts that I think eventually we can come to terms with, but we should just expect there will be some other complexities for the Boeing, the big global and national employers that happen to have a few people that we can work.
We are not short on complexities.
Yes.
Go ahead, Michelle.
Thank you, Chair. And thanks for this clarifying conversation. I would like to bring this back to the Communications and Community Engagement Committee and our consultant, actually, because I think this is worth spending some time creating some plain language explainers about. I think that it's going to be really important to acknowledge the valid concern that advocates have about whether we are backing away from the commitment to the shared goal of what a universal health plan means. And that, I think that there have been many attempts in the United States where a kind of watered down policy approach was what was happening. And I think what I hear you saying and what I agree with is that what we're trying to do is continue to pursue the goal as the legislature and the task force and Oregonians have charged us with, but we are trying to be really honest and have integrity in our communication, because I think there's a real risk in claiming something is single payer when it cannot be. And then when we go into implementation and start dealing with some of those complexities of interfacing with other systems, that is going to impact efficiencies, it's going to impact timeline, it's going to impact how the plan can be implemented. And I think that gives that could undermine trust in this system if we haven't been clear upfront about those limitations. So I think I'd like to take this back and bring back some recommendations to the board and maybe some plain language resources so that we can be really consistent about how we talk about this, because I think this is a really important issue to flag. And as we go into more active phases now and in future years of statewide community engagement, we're going to need to be ready for this conversation in a way that both acknowledges the fears that people have about, we don't want another, reform instead of the true system that we've asked for, but also being prepared to explain the limitations so that people are ready for them when we encounter them in implementation. So that's my proposal, is that we take it to CECC.
Thank you, Michelle. Yeah, I think that's an excellent idea, and I really appreciate your offer to do that. We desperately need that. I think communicating about this in a way that is clear and honest and expresses our intent. I fully agree with you. We're all on the same page here with what the intent is, but there's some complexities here that we can't ignore for all the reasons that you cited. So thank you. Thank you. Mike, did you have something before we move on? Oh, okay, great. Let's switch over to committee updates. I'm gonna pass it to Cheryl to start with finance and revenue.
Actually, before we go on to that, I'm gonna make a request. We had on the agenda talking about the basic revenue proposal. But since we don't have the updated version of it, and so we wouldn't be able to vote anyway today on that, in the essence, or in thinking about the time that we have, I'll have Cheryl's report out, and then we will move voting on that basic proposal to the next month. That's acceptable.
Yeah, so that was my understanding, is that we
Yeah.
just get a quick overview of where the proposal's headed.
Well, I mean, and Cheryl can give it, we have a longer presentation in there that I think might be
Too much.
too much,
Yeah,
yes.
yeah. So, I mean, I think we can take, 15 minutes to kind of go through, 10, 15 minutes to kind of go through. Because what's remaining is the plan design and then the other committee report. Let's do 10 minutes.
Okay, we'll see.
6.
Okay. Okay, I want to start by saying that most of our committee members did not want to disband this committee, and they were very disappointed that our last meeting was on Tuesday, so I feel like I need to say that right off the start. 7 out of 8 of our committee members attended Tuesday's meeting, March 17th, that was our last meeting. And in the spirit of being precise and concise about the 6 motions that we had, I've actually typed them out, and I'm going to do some reading here. I hope you're okay with that. So the first motion was on the Echo Northwest draft report. That's a 90-page report, by the way. I'm guessing that the Echo Northwest report will be presented at our April meeting. So in light of the fact that most of the committee members did not want to disband the committee and were disappointed about it, the first motion was on the Echo Northwest report, and that was to reject the 90-page report because the Finance and Revenue Committee did not complete its work. So this motion was amended by a 5-2 vote to this, and this is a long amendment. Thank you, Charlie. Echo Northwest report on the Finance and Revenue Committee's recommendations to the Universal Health Plan Governance Board describes in part the work of our committee. The committee does not have time to appropriately approve or disapprove of the report, but we will provide Echo Northwest with comments and suggestions with the understanding that it is up to them to include at their discretion. The committee acknowledges that we did not complete our work to the standards of the guiding document the UHPGB approved on January 10th, 2025. We further acknowledge that we only completed the first 5 bullets of the tasks as outlined in our charter as approved by the UHPGB on July 18th, 2024, and only the first of 2 deliverables described in that charter. We reluctantly accept the board's decision to disband the committee before our work was completed. This motion was passed 5-2. So we didn't vote to reject the 90-page report. In addition, I just wanted to mention that Echo Northwest generously offered to give us another shot at looking at their draft report after they were finishing it based on some other motions that we made and approved. And so they're actually going to send it out to us, I think, like a Word document, right? Mm-hmm. And we are able to track changes for another 2 weeks. So I'm thinking that we'll have till early April to provide those comments, and they will adjust. I'm guessing that we will meet with Echo Northwest, maybe the staff and me, and we'll go over those suggestions to see if they match up, if they agree. And then it's really ultimately up to Echo Northwest on whether they accept those changes or not, because it's their report. It's their report about what we did in this committee. That's what the report is.
Right, and it's their report to the board.
Right,
It's not their report to the committee.
that's right.
So our consultants that we've hired
Mhm.
are accountable to us as a board,
Yes.
not to the Finance and Revenue Committee. So regardless of whether or not the Finance and Revenue Committee members agree with the report,
Mhm.
we've paid and asked Echo Northwest to provide the board with a report, and so
Mm-hmm.
so I appreciate that they've given an opportunity for committee members to decide, but that is not a role of the committee to approve or not approve the report.
I think that's what we agreed on, and that's why there was this amended motion to talk, just say, the status of things. So, let's see, so that's happening. So the second motion was on the reserve funding and financing memo. And that was a document that we all received as committee members, in Word format. And we were able to make track change revisions the last couple of weeks, and some of us did that. So the second motion was on the reserve funding and financing, some component of that memo was to recommend a reserve target of 3 months with a trigger yet to be identified at 1 month. That motion passed 5-2. The third motion was also on the reserve funding and financing memo, and that was to not support the reserve funding and financing memo as currently written. That motion failed 2-2, with 3 committee members abstaining. And what I'll say here is we expect and recommend that the transition committee will further consider reserve funding policy and financing strategies. We just didn't get there. And so, even though that motion failed to not support this memo, we do think all of this topic needs further discussion by the transition committee, but at least we got to a recommendation of the 3 months of reserve target and that 1 month trigger. So that's where we got there. Let's see. Okay, the fourth motion is on the revenue proposal, that, if we have time, we'll take a quick look at, but we had a couple of revisions that we were considering. And so the fourth motion was on the first revision that we were considering, which was to take out the household size rate readjustment and any increased taxes elsewhere. We were kind of thinking of the healthcare personal income tax. Yeah, okay. I don't want to use acronyms if I can. And even though at least I stated this, and I believe this was the consensus of the committee, we totally understood the rationale. But some of us, me included, were worried about the political viability because it would add 1% more somewhere to the tax burden. And we were thinking the healthcare personal.
1 billion.
income tax. Pardon?
1 billion.
Yeah, 1 billion, 1%.
Yeah.
So this motion to take out the household size rate readjustment failed 6-1. The fifth motion was the other revision we were considering, and that was to cover all Medicare Part B premiums with the condition on receiving a Medicare waiver. And this had kind of the same, or I had the same concern about the political viability. This would add another 1 billion, also 1% somewhere of tax burden. So that motion failed 3-3 with 2 committee members abstaining. So the committee agreed, and sorry, transition committee, but we agreed that both of these revisions should be further considered in the transition committee. We just thought it needed further discussion. It just wasn't, we didn't feel comfortable moving it yet in finance and revenue. One suggestion that was made, I jotted down, and I'm not sure in which context this is, or it was just an added suggestion. It was to consider a tiered EPT so that large employers will pay more. So that could be considered in those revision proposals. And last, the sixth motion was to recommend the basic revenue proposal with suggested language revisions that Mimi's working on, that's what she referred to. Acknowledging further work is needed to adequately address cost savings expected with a universal health plan. That motion passed 4-3. One other thing I'll add is that a minority report will be submitted by those committee members who dissented on this motion. So that will be expected, and we said that was okay.
Yes, absolutely, yeah. Can I ask you a question about Medicare? What's the rationale for having people still pay a Part B premium when we've removed premiums from everyone else? Like people that are paying premiums for their commercial insurance aren't gonna pay their premiums anymore, but we want the Medicare eligible folks to still pay their premiums for Part B?
No, that wasn't
I
it.
mean, I'm not saying that's the
I-
rationale, I'm just saying I'm noticing
Uh-huh.
that everywhere else in the plan, we've removed premiums,
Mhm.
but the committee decided to have Medicare eligible folks continue to pay their premium. Why is that?
We did agree on a 100% credit for those premiums, but there's still people who would pay their Part B premium who don't qualify for the credit. And so I mean, it makes total sense to me that we were agreeing to just pay the Part B premium for everybody. And I'm gonna ask, is it okay to ask Charlie? Okay, Charlie, could you explain maybe better than I did?
So the federal government will almost surely not give us Medicare Part B dollars if the premiums are not paid for that individual. And so the notion was, yes, those who would become eligible for Part B money, if they paid their premiums, would pay them, but then the original proposal, the tax would refund them but it would be a non-refundable credit. And so the reason for paying is we want that Part B money. And it's essentially 8,000 per person compared to premiums of about 2,000 per person on average. And so that's the reason for that they should continue to be paid. The reason for the plan continuing to pay them is there will be people who have no liability
Right.
and wouldn't
And then
pay.
they
So
would
yeah,
get the credit,
Yeah.
yeah.
So, but why would anybody? Because Part B pays for ambulatory services.
Right.
And if they're gonna get ambulatory services under the universal health plan, why would anyone pay for Part B premiums?
Bingo. Because, yeah, that's the question. So that's why the plan would pay them. That's what the proposal is. The plan would pay them because we want that money. We want the federal money.
The plan will pay 2,000 per person in order to get 8,000.
8,000.
Yeah, right.
And we maybe
So-
didn't think about that early enough. I mean, I think.
The
this
federal
all
government
came
will
up
not
at the
supply
end.
that money to the state
Right.
if that premium is
Yeah,
not paid.
It was like, oh dear.
Right, so I'm confused about why that wouldn't,
So they
like,
would
why
pay,
we, like you said, we should pay for everyone's premiums.
so they would pay their premium, and then they'd show up for care,
Right,
and then we wouldn't get
We-
reimbursed by Medicare, so it'd be a scramble.
exactly.
Just,
So we're proposing that the proposal was we pay them, but the reason it didn't pass is because people didn't think they had enough time to think about it, and that it would increase the cost of the plan, I guess. Simply it.
Yeah.
And that it has been pushed to the transition.
And I just want to add kind of as an ending statement that we're sorry to push so many big things to the transition committee, but I am happy that 3 of our members out of 7 are going to the transition committee. So we've already had the preliminary discussions and there are all kinds of spreadsheets about this, so they can share that information.
Okay, I just wanted to make sure it wasn't a conceptual or philosophical decision not to do it. It was just like, we didn't consider if we could.
I think we thought the tax credit would take care of it. But then when it was
Yeah,
non-refundable
people
and
that
there were
don't have
people who
liabilities.
wouldn't take care of
Yeah.
it, kind of came up like, that maybe wasn't the best
Yeah,
idea.
got it.
But it came late.
Anything else?
That's
Judy,
all.
too.
I just want to thank the committee. We did a lot of hard work. The staff, Echo Northwest was invaluable too. And again, we still get to comment for a couple more weeks on the report. And, yeah, and then we'll bring our proposal, our final revenue proposal to the next board meeting to vote on. And I would imagine Echo Northwest will also present their report. Did you want to add anything? I know we've probably gone over.
No, Michelle has a comment though.
Oh, thank you. And thanks, Cheryl, for chairing that important committee. I just want to express as a board member my deep appreciation and respect for the work of that committee. I think this was our biggest deliverable, the heaviest lift from the legislature, the piece that hadn't, that the task force hadn't been able to, start really working on. And I know that we're doing this work under not ideal conditions, but I think it's important, and I don't think the board would be successful without that committee. So I know this has been really hard for them to not be able to continue their work. And I just want to say clearly as a board member that it's not because I don't value their expertise and their hard work and what they've contributed to this effort, which I think is really outsized in its impact. But it's really because we also have to do engagement before we submit this to the legislature. And if we had more staff capacity, I would be thrilled to have them continue. So I hope that they didn't take the board's vote as a not valuing their work, but really just as a struggle to deal with the realities and meet all of our deliverables. So if you have a chance to speak with the committee, I hope that that gets passed along. And thanks, Cheryl, for chairing such an important body of work.
Thank you for saying that, Michelle. Really appreciate it. Go ahead, Jean.
Thank you, Michelle. I'd like to underscore the gratitude that I have for the committee's work and diligence. And on the outset, I want to level set expectations about the transition committee. It is not a finance and revenue committee. While there's a process in place for suggesting topics to this committee, there's a whole world of buckets that we have to address in a very short timeline to create a transition plan. Finance is a small piece of it. So this is really the work of the board. We will not be diving deeply into the finance and revenue plan. Period.
Yeah, I agree with that. I think if there's any remaining issues that need to be sorted, it has to happen at the board and not at the transition committee. The role of the transition committee is how do we get from here to there? And that's a really complicated question that they're tackling in a very short time frame. So we can try to address some of the financial questions here. We can invite folks as guest speakers. We can invite people to participate in the board meeting, request written comment from people about our ideas and decisions. I think we can still access the tremendous resources and knowledge base that we have on that committee. So yes, I will add my gratitude to the committee and to all the expertise. I know there's been a ton of work that has gone into it. I will also chime in to point out, because they won't, that our staff is incredibly hardworking and they have been just bombarded this month with work in terms of the engagement process. And the very clear reality, as Michelle alluded to, is that engagement has to happen. And it involves a tremendous amount of staff time and dedication. And they are really struggling to make that happen. It is just not possible for us to keep supporting the committees. We just have to move on and finish the rest of the work that we're committed to. So we did our best to give as much notice as we could about when the committees would be ending and what the deliverable expectations were. And we kind of had to just trust that we get as close as we could to that within our constraints. So much of the work of this board is constrained by time, by money, by staff, and we just have to do the best we can with what we have. So again, deep gratitude to the committee, to Cheryl for chairing it. Officially, April will be our last sort of board meeting where we'll review the committee work because we have a lot of report outs still to go through. So we look forward to those final report outs in April and officially wrapping up committee work in April. Okay.
Thank you.
Okay.
I think I would recommend that we not go through this in detail and rather move on
Yes.
to, what we have
Plan
next.
design.
Yeah, plan design.
Sorry,
Yeah,
here we
so
go.
the Plan
Apologies.
design committee did wrap up with its final meeting as well. And we had really great discussions both about cost containment and about workforce. The committee is not bringing forth a straw proposal about workforce, but we have some ideas and contributions to share for the report, but it didn't really amount to a proposal. But we do have a cost containment proposal, which is in your packet, and I'll turn it over to Lee to go over that.
Oh, and so this is just a list of all of the preliminary proposals put forth by the Plan Design and Expenditure Committee before we get into that cost containment one. And just as a thank you for me for all the enormous body of work that they did. All right, here we go.
All right, so cost containment strategy, we can dive right in here. This is kind of in the same vein as the kind of quality proposal where what we have here is more of a framework. But the committee did discuss, I believe the final number was about 17 potential strategies, which are sort of the kind of bucket from which we would hope that, you know, the public corporation would really be looking at cost containment through. And these ultimately got classified by myself, so they're not perfect, and several of them could fit in multiple, but into these kind of 3 domains is a way of thinking about it. Let's go ahead and zip forward. Yeah, so we have these 3 kind of general domains that we were looking at, and the committee kind of landed on this process by which, you know, a cost containment strategy can't just be focused on any one strategy or really even just one domain. So there's this idea, you were able to read the proposal, where there's really kind of 3 different dimensions on which cost containment strategies should be evaluated. One, trying to tackle multiple domains. So, you know, looking at both system level, provider, and specifically at pharmaceuticals as some of the big buckets where things can be targeted. Also looking at short and long-term impact. So obviously there's what, you know, I've heard termed as sort of the low-hanging fruit, things that you can do that will immediately cut costs. Yeah, it's important to have those for those short-term wins, but it's also important to be investing in, you know, for example, like the primary care and things like that, which we know from our earlier presentation, you're not necessarily going to see those short-term gains, but over 10 years, you are going to start to see on a population level that there is impact costing. So looking at that, and then the one dimension that I wasn't able to show, but I like to imagine coming out from the screen, is really looking at the degree of impact. So what is the amount of change that can be generated relative to the status quo? So we've been in this one system for a very long time. What does it look like when we transform to a universal healthcare system? Can we achieve dramatic gains in that particular? And I believe there's just one more slide.
Oh, I think
Just
that's it.
discussion.
Yeah, so we had a list of system level cost containment strategies that's included in the proposal. And then provider level strategies and then the pharmaceutical strategies. I
Can you
think
go-
they were, yes, on that one. So we had pretty good consensus on these. It seemed to sort of summarize where people thought the biggest potential for cost savings were, specifically on the system level, just the fact of having a single system with a single budget, which is had some cost growth and containments, that alone would be great. And then consolidations in terms of state purchasing and saving administrative costs, utilizing global budgets whenever we can, the standard fee schedule with reference pricing, and then the single formulary in terms of a pharmaceutical. So those are like the biggest pieces. There wasn't anything that was super controversial here. It's all stuff that we've talked about before in terms of our stepping stones and how we would approach it. I think as John was saying earlier, that there's some pretty evidence-based, well-established ideas for like how you can take costs on a system levels. So yeah. Go ahead, Mary.
Is the universal fee schedule, is that what we've been referring to as normalization?
Normalization, right?
Thank you.
If everybody pays the same price for the same service.
Yes.
Service, yes, this is different way of saying the same thing, yeah.
Okay, great. And then explore administratively streamlined prior authorizations. What did that mean?
Right, so the idea that prior authorizations, of course, are like administratively complex and expensive
Yes.
and don't help, and
Right.
we want to get rid of them as much as possible. And so access to sort of specialty drugs, specialty procedures, you know, expensive tests or procedures, there still should be a pathway where there's some check
It's
on that,
different.
but it's way simplified.
Okay,
Yeah.
thank you.
Anything else?
So this one should have a vote because there's an
Yes.
actual proposal. Okay,
Yeah.
sorry, just let's make sure you.
Okay, is there a motion to approve the cost containment strategy as outlined and as in your packet? Move to approve. Is there a second? A second. Is there any discussion, further discussion?
Yeah.
Go ahead, Mike.
So and I'm not sure to what extent I should bring this up now versus the transition committee, but I think it would be very helpful to figure out in the next 3 to 4 months what the board wants to do in its own work sessions and what scope it wants the transition committee to focus on. So I'll be very simplistic. I'm quite comfortable with the basic charge of the transition committee. What I'm not comfortable with is I think there are a few things that either the board needs to wrestle with it or they need to wrestle it with the transition committee. And it would be helpful, because we haven't, we're gonna start the transition committee in a half an hour. Be very helpful to have at least a point of view going into that meeting about what the pieces of emphasis are. So I hear you saying you gotta vote for 17 items. That really doesn't give, from my perspective, a lot of clarity. The clarity to me is it that we want to look at administrative costs, both for the health plan and the providers? Do we want to have a health information strategy? And if so, is it 1, 2, or 3, as I mentioned to John? To what extent are we capable of doing basic work with pharmaceuticals to suggest some things such that the board would be comfortable making then adjustments in our cost structure that in turn will affect when we recalculate what the APT and others are. So I'm just bringing up the basic thing. I don't have an answer for this, but just
Yeah, neither do I. And I
how
think
much, how much should
there's
be
a level.
transition?
Yeah.
And how much should be?
We get it,
board?
and we are gonna come nowhere close to being able to be that specific. I mean, I think our goal with this is to give a strategy and an outline for how you would approach cost containment. But we don't have the expertise or the time to get into those kind of details. But the idea is, here's our idea of how cost containment would work. But really what we want to focus on for this discussion, it's been moved and seconded, is that what is listed as a cost containment strategy. Again, it's a structure for a strategy. Is there any discussion about that strategy? And then the role of the transition committee versus the board, we'll have to discuss when we talk about the transition committee in a moment. But the motion on the table is for the strategy as is written in the proposal. Go ahead, Marina.
My question is back to my other thing about normalization, quote unquote, or if we vote yes, okay, I'm basically understanding what we're doing here, but it's like, then will that be further defined somewhere?
Well, of course, yeah, that's what I was just saying to Mike, yeah.
Okay, I didn't understand that.
Yeah, yeah,
Okay.
so in the sense of, we know that a standardized fee schedule, you have to have one. If there's one payer, there's one fee
Right.
schedule.
Yeah.
Right, like that, there's no multiple payers paying
Yeah.
different for the same service. So, but developing it, what it would look like
Yes.
and how it, oh yeah, that is way down the road.
Yeah.
And by somebody smarter than us. To figure that out. Yeah, but that one would exist is the key part of the cost containment. Yeah, so that's what I mean by like, it's a strategy decision without going into the details of exactly what it is. But yeah, that's how we imagine that cost containment would happen, is through those mechanisms. So I think of it as like, just like we did with the quality strategy, we have to put mechanisms in place for that to happen without making clear decisions about like, exactly how many metrics are there. That's not the role of this board. It's just to lay out the strategy for how it would work. And then if we have more resources to kind of continue to flesh this out, that would all happen through the public corporation. Any other questions? Okay, it's been moved and seconded. Any further discussion? Let's do a roll call vote.
Ellen Belanca,
Yes.
Chun-Wei Chi,
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich,
Yes.
Mike Leahy.
Yes.
Passes, thank you.
Great. So that is officially our final report from the Plan Design and Expenditures Committee. We won't have anything to finish up in April. So on behalf of the whole board, I want to thank all of the members of the Plan Design Expenditures Committee. As Mimi said in her first slide, we've put together a whole slew of proposals that have influenced the work of this board. And I'm deeply grateful for all the members of that committee for their participation and their expertise. So thank you to all of them. And I will turn it over now to Judy.
Thank you. So Helen did introduce a little bit our topic. We do have one more meeting that will be next week. So Lee, perhaps you can go through not in detail about each program, and then I'll wrap up with where we're sitting with consensus.
All right, so we talked a little bit about interaction with federal health care programs on the next slide. Again, as noted earlier, of course, Oregon can coordinate with federal healthcare programs, but due to the nature of, being a state and federal system, we can't tell them what to do or make them go away. So it's really about how do we work with them. Next slide, please. This just notable, one of the few graphics I was able to locate that actually does identify some of these smaller federal programs. I think the useful thing here is just a little bit of context. It was noted earlier, this is a small percentage. But when we look at those covered lives, we're talking a little over 7% of the population of Oregon is involved in one of these smaller federal programs that we're talking about. And about 4%, so about 1 in 25 Oregonians would be considered active users of those programs. Next slide. Let's zip forward to the table. All right, so this is just the quick summary of the 4 different programs that we looked at. This is the VA Health System, TRICARE, Indian Health Services, and Federal Employee Health Benefits. Now, there's really kind of one or a couple interesting things I want to note. First of all, the VA Health System and Indian Health Services, those are notable because those are really care delivery systems. They have their own facilities. They can operate sort of as a closed network. So operations kind of looked at them in one chunk, and then they look separately at TRICARE and the Federal Employee Health Benefits because those two operate much more like a traditional insurance program. So the way those are going to interact are a little bit different. What's also kind of interesting is just noting that next column over the dual coverage hierarchy. This is something that is yet to be discussed, and in fact, I believe is explicitly on the transition committees. One of the first to-dos, but looking at how would those coverages interact if someone, for instance, was covered by the VA as well, of course, as a universal health plan because they live in Oregon. So just some interesting things that remain to be worked out. Then forward. This was really discussed earlier, so we can skip it and I'll turn it over.
Sure. Thank you. I want to extend my appreciation to Operations Committee as well. The discussion around this idea, this concept was as much posture and philosophy harkening back to our principles as a board as much as it was technical and operational. And so after discussion among the board, there's consensus or discussion among the committee, there's consensus among the members that the Universal Health Plan should wrap around federal care delivery programs and think about the people. So without interfering with the operation of those systems. So that enables care coordination and consideration of exploring some IT integration. We still need to discuss how the UHP would treat individuals who are covered by the federally administered health insurance programs like TRICARE, and which coverage is primary. How would billing be handled for other insurance through the UHP to providers? So that's where the committee sits. Hopefully they'll be able to have a discussion about that next week and come back to the board with a recommendation.
Great. Anything else for operations? Okay, passing it to you, Amy and Michelle, for community engagement communications.
All right, so as you've heard, we are deep in the focus group part of our work. So just as a quick reminder for the public, our focus group work is gathering structured input from 8 stakeholder categories, which are employers, large and small, business organizations, healthcare providers, healthcare insurers, coordinated care organizations, healthcare consumers, disability-led organizations, and community-based organizations. This is not a comprehensive engagement process. We won't capture every voice within these categories, given our capacity and resources. These virtual forums are capped at 12 to 15 participants, with some categories having multiple gatherings and others just one. Participants are selected based on geographic diversity, centering those most impacted, relevance to the draft universal health plan, and avoiding duplication of input. So to date, we've completed 4 focus groups with disability-led organizations, CCOs, commercial insurers, and healthcare insurers. And I think we have been a little bit more successful than the task force at getting some of the insurers to the table. We've got
Indeed, we
some.
We certainly have. We're very grateful for their
So,
input.
yes. We have 11 more scheduled through March 31st, and that's, you know, a lot for the next week and a half. April will shift it to analysis and report writing by our consultant from Artemis Consulting. We also anticipate the potential need for a special board meeting that we are proposing April 30th at 9 a.m. to get hear back from the report and go through the report from the focus groups. I think staff will be sending an email to make sure that works for the majority of us. And then our March 11th KEC meeting, the committee began planning for broader engagement activities from April through September and discussed what to recommend to the legislature on future engagement, including potential funding for a statewide poll and statewide engagement strategies, such as a civic assembly, which one of our KEC members brought up. It was also our first meeting with expanded opportunity to hear public comment. We moved our meetings from to 4 to 6 to get that. We reserve 1 hour starting at 5 p.m. at each KEC monthly meeting to hear from the public, and we have extended the time limit up to 5 minutes per person in that space. And we hope that all of you can help spread the word so that we can get more of that. At this March 11th meeting, we had 3 people giving public comment and 1 written comment. To save time, to make sure we get to this public comment today, we'll have that emailed out to the board, and we're still kind of trying to figure out the best strategy of giving that input from that new place. And then just a reminder on external engagement protocols, since many of us are participating in external events like the April town halls organized by Healthcare for All Oregon. A reminder of our protocol: you're welcome to present using the board's updated slides. If you notify me, the executive director, in doing so, you are not representing the board in an official capacity and should not engage in speculation or give answers on matters the board hasn't evaluated or decided. We think this kind of external engagement is important, especially with a draft plan in hand, but ask that everyone help to combat confusion and be clear they're speaking as an individual, not on behalf of the board. And I think we are working on kind of a consistent slide set that will be used for those HCO town halls, so that whether Mike or myself or Mary Lou is doing it. I also want to encourage, if 2 of you are doing the same one, like Mary Lou and I and Eugene, we should coordinate just so we are kind of who's saying what and not stepping over each other's toes. That's my update. Michelle, do you have anything to add?
Great. Any questions?
Just a question, maybe. There was a document shared with us of the documents going to all these different
The focus
groups.
groups.
At what point will we be,
When we're done with the focus groups, I think, just to keep that kind of, you know.
What was your question, Mike?
The document, the focus.
Yeah,
groups.
but I didn't hear his question.
the question is, at what point does that become public information?
Yeah.
Oh, public information. Okay.
Yeah, and I will say, well, let the co-chairs speak for themselves, but the co-chairs discuss this in detail. I don't know if you or Michelle would like to kind of explain the rationale behind waiting until all of the groups are finished before sharing that more broadly.
So a week and a half longer.
Okay.
Just to kind of
And
preserve
so that stuff,
the focus.
that stuff could be incorporated when we're meeting before these different groups.
Yeah, yes,
and-
and I think, having some kind of handout for the HCO town
Great.
halls. And
Okay.
so, so
Thank
we
you.
are
Thanks for
looking at
clarifying that.
using that.
Yeah.
But, you know, it may be tweaked based on the feedback from the focus groups, I'm not sure, so, yeah. And if it's confusing or needs more plain language.
I just want to say from the, I've spoken with people at HCO and I've been encouraging them not to develop their own background paper, to wait.
Yes.
So that we don't have dueling background papers going on. And so just that urgency, and I know that it's coming, but, getting that released as soon as you could, so that the advocates are
Yes,
feeling comfortable that
we've
there's something that
spoken-
they can take out that,
We've spoken with
Yeah.
the coordinator for the
Great.
focus groups as well.
marvelous.
Thank you to that committee. I'll pass it to Judy and Mike about transition.
I didn't even include
So
it.
transition committee will be meeting right after this. We're gonna be going over the charter. Appreciation to all of the chairs who nominated membership for that committee. As well as some thought that's gone into the bucket of work that needs to happen between now and the time we hand a transition recommendations to the board. There will be lots of dialogue back and forth. The unique structure of that transition committee is there will be 2 meetings for every board meeting, and the intention there in the design is that there will be a dialogue back and forth between the board and decision making and requests and recommendations from the committee. Anything else to add? What?
Well, first of all, I agree with all that. It's my hope that we can do the basics of what we've suggested here. And that, to the extent that we can come up with things that are a little bit clearer, then I think will actually, make for a stronger case for, the eventual plan we come up with. Because my own sense is it's something that's a little bit bolder and, but that means we just have to do some focused homework on a few topics.
I'm a little confused, and I'm sure it'll be coming out about all these various meetings. And, talking about the special meeting that you talked about from the CECC.
April
April 30th, and what time, and, but anyway, just kind of.
There's not a planned special meeting yet. We're gonna talk
No.
about it.
Oh, there's
There's
not.
there's no plan right
Yeah,
now.
that's a proposed.
It's a proposal.
date
We're
and
just gonna
time
talk about it. We'll
that
let you know.
Will get emailed out
Okay,
to make sure that that works for
Yeah.
the
okay,
majority.
all right, thank you.
And mine's up for the next step. So I don't know for that yet.
Okay, anything else about, community engagement and communications? Or transition, I apologize, transition. Okay, so in terms of next steps for, you wanted to ask about, future topics or next steps?
Yeah, my question is, since Bruce is still on leave, and I'm not sure if we know about the timing.
He's coming back in July.
Okay, awesome. Because that's what I wanted to ask is, if we will somehow be able to get his review and input on a version of our draft plan, because I think.
Oh. We'd certainly email it to him.
Absolutely. Any other thoughts on future topics, for next meetings? With staff and I have some ideas, but yes, go ahead.
One topic, not necessarily immediate in April, but in the near future, we might want to discuss is the health information system. And that will be health information system, that will be
Yes.
very vital, not just for the operation, but also for the population health. In my earlier comment, I mentioned, in terms of the organizational structures, Taiwan's universal healthcare has separate independent as the first level hierarchies information system. And that information system, including the payment system. And it expedite the payment and simplify the payment, but also they have the so-called Medi-Cloud. For providers, they have access to all information, and it's also active, including prescription, but also for all residents. All residents can access their health data, their health information, and vaccination, and Taiwan's information system worked superbly well, become a model during the pandemic, including distributing the ration masks when initially there was shortage of masks, tracking people who coming from overseas and everything. So that will be a vital, not just for the smooth operation of the universal healthcare, but if we design it well, it has potential to make a lot of savings. That's why Taiwan can operate less than 2% administrative costs with 3,000 people administering 23.5 million people in universal health. Very powerful.
Thank you. Okay, we are at 12:30. We were hoping to have some time for public comment, and we have 6 people signed up. And I'm gonna defer to Judy and Mike and Mimi, if you wanna spend 5 minutes on public comment and then have a 10-minute break before the transition committee meeting. Is that okay? Okay with you? Okay, so
7 minutes?
Yeah, so I'm gonna ask our 6 public commenters to do your best to please limit your comments to 1 minute. We can start with Marisabel Governor.
Oh, good heavens, I had no idea I was making a public comment.
Oh, did you? I thought you signed up for public comment.
I just signed
Oh.
up because I was here.
Oh, okay.
I'll take the
Oh,
opportunity to
okay,
make a
yes,
public
please.
comment
Yes.
and thank all of you for all your hard work. You're changing the course of history. Remember that every day when you get frustrated. Thank you.
Thank you. And then Mike Huntington.
Again, thank you, every one of you. My comments regarding value-based payments and to access all possible savings of costs, not only to government, but to the public, be fully assessed. And this needs to be clearly stated in order to get voter understanding and support. Just as a comment on the Sabuka bill, as of yesterday, Senator Markey's staff has expressed continued support for Sabuka and either eliminating or at least modifying the language that addresses abortion and gender care, which doesn't need to be in there. It should not be prescriptive about any kind of treatment. And it would create unsurmountable opposition from both sides of the aisle. Thanks.
Thanks. Next is Elliot Pearl.
Elliot is online. Let me give 1 second. Okay, Elliot, you should have the ability to unmute and share your comment now.
Yes, thank you. And I will try to keep things brief, but I am speaking on behalf of 129 Healthcare for All Oregon supporters. So we were just wanting to comment on the Milliman report because, you know, as has been shared today, we don't quite have answers for a realistic cost estimate, especially because it must account for like all the savings that we know would come as were discussed. So we just wanted to ask the board to clarify, you know, who's responsible for developing a realistic cost model, and then establish a timeline with clear milestones, just so that the public can be a little more aware of that. And then, you know, obviously share the plan publicly. But I know that you all are doing such important work, and we just wanted to highlight that we appreciate all the work you're doing. And we also wanted to provide a number of resources for this topic as well. So we have a second testimony that includes a bunch of information for you all to peruse at your leisure.
Thanks, Elliot. Alex Polikoff.
Okay. Alex, you should be able to unmute and share your comment now.
Okay, can you hear me now?
Yep.
Yes, we can. Alex. Go ahead.
My video keeps cutting out.
Now
Thank
we
you.
can see you.
Okay, great. Thanks. It looks like I'm dark. Thanks to the board. Dr. McConnell's presentation today was awesome. I just want to reemphasize what he said. Visibility is huge. And what's the most visible thing people are going to look at? The tax rate, right? So that healthcare personal income tax, I think it really needs to be under 10% to even have any chance. This work is way too important to fail on like first looks. So that's huge. I think Finance and Revenue did an excellent job. I mean, kudos to them. I think their funding sources are right on, but you got to get that thing under 10%. And there's, sorry, there's lots of levers they can pull. There's the thresholds they use. You can rebalance that, but that's a huge thing. Also, sorry, I think, you know, it is effectively a progressive rate for both payroll and the personal income tax, but I think there actually needs to be a rate that's progressive, not just a progressive tax in all its features. Lastly, another thing Dr. McConnell brought up as far as visibility goes, medical tourism. And I just, at the last board meeting, there was a vote to recommend by the operations committee, full benefits upon attestation of intent to reside in Oregon. I think that's going to be a visibility problem. You can't have people just coming into the state from other states that don't have health care, you know, and then say, I'm going to live here. Then they get care and then go back in a couple of weeks or whatever. People are going to look at that. So visibility is huge. Please listen to what Dr. McConnell said. And again, thanks for all your work.
Thanks, Alex. Mike, I just realized you were on this list twice. So I'm gonna assume you said what you need to say, and I'm gonna move on to Lou Sinninger. Okay, Lou, you should be able to.
I'm here. I'm trying to get this open here. There we go. They're saying, okay,
Yep, we can hear you, Lou.
all right, thank you. There's obviously too many things left undone. But you all have done a fantastic job, especially considering that almost all of you, except Mimi, are volunteers. So that takes me to where do we go next? So it seems to me, and thank you, Helen, for your presentation on the one state and a federal system. I think it crystallized what we're in and helps us get to the next step. But I do think that we need to think about where to next, right? To succeed, we have to build a better system, giving more benefits to everybody or almost everybody for less money, right? To do this, we're going to need to have we're going to have to go to the legislators to build a better universal health plan board. We're going to have to hire more staff to get these things narrowed down so that we'll have a complete plan within the next 2 years. So please go to the legislators with a with a big plan in mind. There still hasn't been done. One thing that we need to do is to do the complete analysis of where the savings will be. And remember, you're changing from a profit-making system into a care system, from an individual system to a social system. This is a dynamic step. Thank you very much.
Thanks, Lou, we appreciate it. And we have a final reflection from Judy before we wrap up.
Thanks, I'll be brief. So really, I was thinking about Amanda Gorman. I don't know if you have a slide.
I don't have a slide. I'm so
That's
sorry.
fine. I'll just, you've probably heard this poem that she said, but I just want to pull out this line. Because being American is more than a pride we inherit. It's the past we step into and how we repair it. And I think it acknowledges and recognizes where we've come from, the hot mess it is, and that's our role. So
It's lovely. Thank you. Her. Hey, quick volunteers for next month's reflection. Need a volunteer for next month's reflection and then we can adjourn. Okay, great. Thank you. All right. And with that, we are adjourned. Thank you so much.